Welcome back to the National Cancer Prevention Workshop, sponsored each year by the organization lesscancer.org. I'm Miles O'Brien. I'm the chairman of the board of Less Cancer, and we're conducting our series this year we're calling the John Dingell Cancer Health Disparities Access Interviews. And it is what it says it is. We're talking about disparities on several levels and how that impacts incidence of cancer and cancer deaths in particular. On this discussion, we're going to be joined by Mandi Pratt-Chapman. She is the Associate Center Director for Community Outreach, Engagement, and Equity. She's also an Associate Professor of Medicine at the George Washington University Cancer Center. And today we're going to talk about disparities in the LGBTQ community and how that impacts health outcomes. Mandi, great to have you with us, first of all.
Yeah, thanks for having me.
Okay, let's start with a basic fundamental philosophical statement. I think we can all agree on this. Who we are shouldn't affect our health outcomes, right?
Absolutely. Absolutely. Yes, and who we are doesn't really affect our health outcomes. It's how we're treated that affects our health outcomes. So being queer doesn't make us have poor outcomes. It's transphobia and homophobia and the exchanges that we get in terms of long-term social interactions, stigma, chronic stress, and healthcare system structural bias that leads to those poorer outcomes.
So there's a statistic I saw you write about not too long ago, which really caught my attention, and it should catch all of our attention. Social determinants account for an 80% incidence of healthcare disparities. 80%. Tell us a little bit more about that.
Yeah, great observation. And some people will, these are numbers that have ranges. So that's kind of the most extreme kind of way of wording this, but that includes access to healthcare, right? So healthcare provision itself, healthcare delivery of clinical services is about 20% of our health outcomes. 80% include things like where we live, whether we can walk, play, bike, exercise in a safe area, whether we have access to fresh food and we know how to make fresh food and actually enjoy eating it, our financial stability, our social support, and again, our access to healthcare. So in Washington, D.C., for example, we have almost all of our healthcare facilities in the northwest, northeast parts of the city. And we have drastic disparities between white and Black populations, with most people in the southeast part of the city having to travel to the other part of the city, the more affluent part of the city, for healthcare. So access to healthcare is impaired by distance, by transportation infrastructure, location of facility, those kinds of things.
So I want to talk a little bit more about how LGBTQ people are treated by the healthcare system, but let's dig in a little deeper on some of the reasons they might not be as healthy going in the door. Mm-hmm. First of all, if you are stigmatized, if you are discriminated against, there's lots of studies out there that would tell you that discrimination, at the very least, increases your stress. And if you have more stress, you're not in as good health. Is it as simple as that?
Part of it is as simple as that. When you have chronic stress, there's something called an allostatic load, right? Where your stress level is higher, so it increases your chances of inflammation. So something that a lot of people don't know is that we all have cancer cells inside of us. We always have these aberrant cells that are circulating inside of us. But if we have conditions that facilitate those cells to proliferate, those are those instances where your stress level, your degree of trauma can become kind of petri dishes for those cancer cells in order to get them to proliferate. So stress doesn't cause cancer, but it might create the conditions under which circulating aberrant cells become more prolific, right? And so this kind of chronic stress, increased inflammation leads to these outcomes, but there's other factors too. So one thing that people are not always aware of or don't always think about is the fact that tobacco companies and alcohol companies have really targeted queer communities for a long time. And part of that was because bars were for a long time the only safe spaces for LGBT people to congregate and not be afraid of repercussions. And there's been obviously some civil action and things that have historical civil actions that have occurred in bars, and the Stonewall riots and all of that. So, the fact that some of our coping mechanisms, which in and of themselves are not, I don't think are a moral judgment, but the fact that some of our coping mechanisms end up being maladaptive in that they also increase the likelihood of cells changing because of the influence of alcohol, the influence of tobacco, and how those can change cells to be more carcinogenic or more cancerous. And then you add the stress to that. So we have risk factors, greater alcohol consumption, tobacco use, and then we have family factors, historically, a lot of alienated family, less social support, and then social stigma. This is kind of a recipe of creating the environment under which cancer can kind of proliferate, if that makes sense.
Well, so is it possible to make a sweeping statement that the LGBTQ community is less healthy?
I don't think so. I mean, I think that there's a lot of factors. I think that there are differences within the LGBT community. For a long time, we've been lumped together. And the reality is that within the LGBTQI umbrella, gay men actually have some of the greatest financial stability of any population. And transgender people historically have had some of the worst financial stability because of family rejection. I think based on generation, that's also changing. I think that at younger people, this is not at all as much of an issue. I have a 15-year-old daughter that doesn't even understand why this is such a big issue to us. So I think generationally there are differences. I think based on level of social support, I think geographically there are differences. So where you are in an affirming environment and you have strong social support and queerness is not something that's stigmatized, then I think you're at less risk, right, for those poor outcomes. If you're in an environment where you're afraid to disclose, where you may get strange looks or be not sure if you're safe to disclose, those definitely impact people wanting to access healthcare, the degree to which people go for preventive care versus emergency care, and the type of care that they receive. So I think there's a lot of differences. And I think that because we don't routinely collect sexual orientation and gender identity data, and we don't collect stratified data, it's very hard to make generalizations. We can only make predictions in relation to associations that we know exist. Like I had discussed before, we know that alcohol is a carcinogen. We know that tobacco is a carcinogen. We know that stress is a carcinogen, right? So like, if you add all these things together, there's a reasonably good premise on which to say this person may have poor health outcomes. But if you counter that with resiliency and social support, and you and those factors are not at play, then no, you can't make a blanket statement about LGBTQI people.
So it's complicated. It sounds like it would be helpful if the research was more targeted to the individual and the type of person they are. Now, I would imagine that people who are transitioning, for example, and who have high rates of suicide or at least suicidal ideation, might have worse health outcomes. Do we know for sure, though?
People who have suicidal ideation, regardless of their sexual orientation, or could you clarify?
No, in other words, people who are faced with they're reckoning with their identity, and that often leads to depression and suicidal ideations, etc. Are those people more impacted by this stigmatization, put it that way?
Yeah, I mean, I think you raised a really important point. I think there are different levels of stigma, and one of those levels of stigma is internalized stigma, right? So like if we have challenges in aligning with who we are or accepting who we are. For example, I was raised in a very traditional, fundamental evangelical environment. I came out very late in life. I didn't necessarily feel stigmatized about my identity, but it felt very foreign to me and didn't feel like it fit. And so for about 2 years after I came out as a queer woman, I actually felt like a straight woman that dated women. You know what I mean? Because in my head, there was this kind of socialization of this is the label that you belong to. But to your point, I think I don't know that I can speak to cancer specific outcomes, but certainly in any kind of environment where someone doesn't have the support to be who they are and to have kind of that pride in self, regardless of who you are, that's going to definitely impact your overall health. And mental health is a crisis in this country. I mean, this is something that we don't talk about often enough. It completely impedes our physical functionality. It impedes our ability to work, our ability to do many, many things. So it's definitely a critical metric of health that we don't tend to pay attention to as much as physical impairment. So I think that's a really critical point that you just raised. Yeah.
So to what extent does all of this inhibit people in this broad community, which we just described, inhibit them from reaching out to the healthcare system, first of all? I mean, are they reluctant to go see a doctor because of the potential, the mistrust or the stigma or whatever concern they might feel?
Yeah, again, I don't think we can make blanket statements, but I can give you some examples. So I can tell you that a good friend of mine who was a football player, she considers herself butch lesbian, has never been to a gynecologist ever,
Wow.
except for when she had her hysterectomy.
Have you encouraged her to go?
Of course, but she's very stubborn. So no, you know what I mean? And all of her colleagues that she's aware of who also played football for the DC Divas, she may or may not have had conversations with them. I don't know. But her assumption is none of them have gone either. And so there's definitely this sense of, oh, well, that's not for me. That's for feminine women. And again, that is not a blanket statement. That's an anecdote based on qualitative personal data. Like, I don't know what the statistics are. I will say that there have been a few small studies about trans individuals and the degree of gender dysphoria, particularly in, quote, women's centers. So centers where there's a lot of pink, that the title of the center might say women's center, where people may be sitting and feel really out of place in the waiting room. For trans men, there have been several studies indicating that there's lower uptake for cervical cancer screening. And part of that may be, definitely gender dysphoria, also the environmental cues that don't seem welcoming, and also physical distress, like just kind of not wanting to align with that body part, and also kind of procedures that are not necessarily affirming and can be adapted if clinicians are appropriately trained in trauma-informed care to make things more comfortable, right? So there's definitely some evidence that trans men have a lower uptake of cervical cancer screening. I also have a friend who recently was told, you don't need to see a gynecologist, or actually she was told 20 years ago, you don't need to see a gynecologist because you've only had 2 partners in your life and they were both women, so you're, quote, basically a nun. And she ended up having profuse bleeding for a year. And then it ended up that she had uterine fibroids, so she did not have cancer, but she just did not go to a gynecologist for a really long time because she was told she didn't need to. So I think there's a lot of misperceptions in various subpopulations of the queer community, as well as among healthcare providers in terms of level of risk. On the other side of that, there's a little bit of data that would indicate that, for example, for trans women, mammography might actually be an affirming procedure, right? So like, when do you start screening for transgender women? And again, the best consensus evidence that we have is we know that age and estrogen are the primary factors for breast cancer, right? So the older you are and the longer exposure you might have had to estrogen, the more likely you may have had a breast cancer development. So for women who are over the age of 50 with exposure to estrogen for at least 5 years, right now consensus is like you should start getting your mammograms similar to cisgender women. But again, we need routine data collection so we can continue to refine clinical care guidance, because typically all of our cancer screening guidance has been made for cisgender populations. So by cisgender, I mean people who were assigned a certain sex at birth and continue to identify with the gender to which they were assigned. Most of our research has focused in that area. And without collection of sexual orientation and gender identity data, we're not going to move the evidence base to be able to provide more tailored recommendations for people in clinical care settings.
So what are the rules in this area, though? I know the Trump administration tried to walk back some things. Where does it stand right now? What do the rules tell healthcare providers about how to handle this?
So the Trump administration did issue a proposed rule that allowed providers to deny care to any patient with whom they had moral or religious objection. The degree to which that was enforced, I don't know. I mean, my understanding is that any institution that takes Medicare dollars would be subject to Joint Commission requirements that require non-discrimination. So I don't know the degree to which institutions changed policy or what they did under that proposed rule, but I will say that the Biden administration reversed that and reinforced protections on the basis of sex and gender so that you cannot be denied a healthcare service on the basis of your sex assigned at birth, your sexual orientation, your gender identity, or your gender presentation. So these are really important protections. And I often say to people when I'm delivering healthcare trainings that we have to remember that healthcare is not a bi-directional relationship. You're not in a clinical environment as a clinician to get something from your patient. You're there to provide for your patient. So this idea of denying healthcare on the basis of moral objection seems very spurious to me because you're in there to provide a service to optimize the health of the person coming in the door. And it's not the provider's role to decide, I'm not going to give you my highly skilled kind of expertise in this area because I don't agree with something. There's lots of things we don't ask patients about that may or may not have anything to do with their health that providers may never know about and may morally object to. But that's not really the place of the healthcare enterprise. It's supposed to be a relationship where people are coming in for their wellness to protect their health and not supposed to be pleasing the healthcare provider in order to get care.
It doesn't seem like that jives very well with the oath you all take, the Hippocratic Oath.
Right, exactly. Doing no harm. So absolutely. I mean, you're there to provide care for the person coming in the door, and you're supposed to be providing the optimal wellness for that individual, not necessarily taking, you have the opportunity to take care of your own health when you walk in the door as a patient, even if you're a healthcare provider. But as a provider, it's not really of benefit to population health. It's certainly not benefit to the patient, and it's not really within the scope of the ethical responsibilities of the provider to deny service, in my opinion.
So you wrote in an editorial for Newsweek in 2021. I thought that this was very thought-provoking. Not discriminating is not enough. It kind of reminds me of the discussion which has come out of all the police brutality, the anti-racism approach to things. We can't just sit back collectively, can we?
No, and thank you for raising that because, I think sometimes we think if we're not part of the problem, we're fine, right? But the reality is that our country, and I know this is going to be unpopular with some people, and that's okay because it's America. It's okay to have differences of opinion and interpretation and perspectives. But we're a country that I think I can say factually was built on the basis of capitalism. And so healthcare is a capitalist enterprise. And as a nation, historically and factually, we were also built on the back of slavery. And in the process of the last 400 years, both people of color and queer individuals have been institutionalized and involuntarily institutionalized, experimented on, and restrained on the basis of their identity. And these structures were put in place not necessarily to discriminate, although you could make an argument that that was intentional since they were built for a certain population. But these structures were put in place in the service of certain people, namely, definitely white men, sometimes white women. And in order to deconstruct the bias that's embedded in these structures, we all have to be part of that dismantling process. So Ibram Kendi says that, you can't really be non-racist. You can be racist and you can be anti-racist, but if you're neutral, you're kind of part of the problem. And I would agree with that. And I would also say the same when it comes to discrimination or health disparities for any population. If we aren't part of dismantling the structures that have embedded bias that inordinately favor certain groups over other groups, mostly unintentionally, but historically intentionally, then we're not part of the solution.
Let's move quickly from the clinical to the research side of it. I think in that same article, you were talking a little bit about clinical trials and how in many cases, people in this category are excluded for various reasons, and that has consequences which are a little harder to quantify, but I'm sure are very real.
Yeah, this gets back to the screening criteria, right? So you can't create screening guidelines so the U.S. Preventive Services Task Force is a wonderful service of the healthcare delivery system, and they look across the most rigorous trials to synthesize the evidence to create guidelines. But if you don't have demographic data collected in those studies, you can't say anything about differences in how people are experiencing certain health conditions or certain health outcomes or how they should be treated differently. And so in clinical trials, we often, almost never actually collect sexual orientation and gender identity data. And we often say things like women instead of people with a cervix, or we say, for example, I had to go in for an appointment a few weeks ago and I was required to take a pregnancy test, and I couldn't do the procedure without the pregnancy test, even though I could tell them for sure that I was not pregnant. And so these kinds of archaic requirements, I am pushing researchers to think about, what do we really mean when we say we want to enroll women in the study? Are we saying we want to enroll women in the study, or are we saying we want to enroll people with a cervix? Are we saying we want to enroll men in the study, or are we looking at long-term prostate cancer risk, because trans women usually retain their prostate, right? So let's be clear about what we're actually studying. Some of the movement in this area, I'm part of the American Society of Clinical Oncology Sexual and Gender Minority Task Force, and we created a tip sheet for clinical research. And one of our recommendations is to do anatomy inventories or organ inventories. And I know I was also part of a conversation around HEDIS measures, which is a quality measure in healthcare. And how do we start collecting some of these data? And these data are going to be required soon of institutions to report on the basis of anatomy as opposed to a pronoun, right? So is the patient eligible for cervical screening because did they have a cervix? So whether they had a hysterectomy because they were a cisgender female, or whether they had a hysterectomy as gender corrective surgery as a transgender male, or if they were a trans male with a cervix, the important thing is whether you have the body part and whether that body part is still at risk for disease, right? And so we really need to change both our clinical trial eligibility data, the way in which we're reporting those data, and importantly, the way we're discussing those data, so that we're not associating, for example, race as an explanatory factor or queerness as an explanatory factor, but rather all of the experiences that might go into the larger majority of the people of color having a health outcome, right? And all of the stigmatizing experiences and stress that might go into queer populations and experiencing a disproportionate health burden. So being more careful about what are the mechanisms under which these changes are happening, how are populations doing, particularly across different geographic areas, different political contexts, different healthcare contexts, and social support networks. So we have a lot of work to do.
All right, let's end it in the clinic, because I'm certain a few people watching this will want to know how best to create a welcoming environment at the clinical level for people in this category. You mentioned, the pink OB gynecology, obstetric. I'm going to say that wrong. OBGYN.
Okay,
Because I'll stumble over that. But that's a simple example. But when you think about it, of course, that would be off-putting for some people. So what should clinicians do? How should they think about this? How candid should they be? How much should they address this subject or not talk about it?
Yeah, I definitely don't vote for not talking about it. I would say there are four major things I would keep in mind. The first is environmental cues, right? So is your clinic, when you walk in the door, is it going to be welcoming to the patients you serve? Whether those patients speak Spanish, identify as gay, whoever they are. Are there posters? Is the environment welcoming? Are there posters, information in their first language, in terms of people that look like them? There was a study that was done among LGBT individuals, and the findings indicated that queer people want to see a diversity of people, right? We don't want to just see everyone that looks like us. We want to see the array of the human experience, right? And that's what feels welcoming, at least in the context of this study, that's what they found. So environmental cues is very important. And that includes having a space on paperwork to indicate who you are. So don't just have male and female, have male and female, and additional write-in options, transgender. Make sure that you're not making transgender exclusive to man and woman, because you can be a trans woman, you can be a trans man, you may be trans and not want to say that you're trans, but provide the options that align with how people want to express themselves, their names, their pronouns. I talked to someone recently in an interview, and it was really interesting because she was saying that what really turned the needle at her institution in terms of names, everyone was really worried, like, well, we can't ask people what their names are, we need the legal name. And when they finally turned the needle on this, it was because cisgender men were like, yeah, I don't want to be called Jonathan, I want to be called John, or I want to be called Jack. And then all of a sudden people were like, oh yeah, people have a lot of things that they would rather be called in the context of vulnerable clinical environments. It's okay to ask people what they want to be called and how to refer to them. I would say another major thing is self-reflection. Just take a pause, whatever you're assuming, if it's not something you're familiar with, take a pause and think about, how is what just came into my head or what assumption I just made going to affect the comfort and the healthcare and the well-being of the person in front of me? And then just pause and be intentional so that you're acting in the best interest of the patient. Third, collection of SOGI data. So having it on forms, but also routinely collecting sexual orientation and gender identity data, but not requiring patients to answer, because again, depending on the socio-political context, the level of social support that may range from uncomfortable to potentially life compromising in environments that are very transphobic or very homophobic. And then the last thing I would say is representation. This is so key. And I really believe that we are not going to achieve health equity until our provider workforce reflects the diversity of the patient population they're serving. So until our provider workforce and our researcher workforce reflects the diversity of the American population, I don't think we're going to achieve health equity, because the richest and most impactful way that we learn is from direct relationship with each other. And doctors learn from their peers. They respect their peers and they understand each other. So having that lived experience in interaction with diversity is not about the right thing to do. It's about quality. I mean, it is the right thing to do, but it's about quality healthcare. It's about our ability to actually deliver quality healthcare, which we're not going to be able to do without having that diversity at the table.
Great advice, great insights. Mandi, Pratt-Chapman, thank you very much for joining us at the National Cancer Prevention Workshops, John Dingell Cancer Health Disparities and Access Interviews. It's a mouthful, but there you have it. I appreciate your time and thank you for your service to public health.
Absolutely. Thank you.
Hello and welcome back to the National Cancer Prevention Workshop, produced each year by lesscancer.org, an organization that is focused on prevention of cancer. My name is Miles O'Brien. I'm chairman of the board of that organization, and we are conducting a series of conversations this year with thought leaders, educators, doctors who are focused on prevention of cancer, specifically how disparities in healthcare access affect cancer and its spread. We're calling this the John Dingell Cancer Health Disparities and Access Interviews. And we're proud to have as our guest today, Dr. Vikrant Sahasrabuddhe. He is the Deputy Chief of the Breast and Gynecological Cancer Research Group and the Program Director in the Division of Cancer Prevention at the National Cancer Institute. Vic, it's really nice to have you with us. Thank you for your time.
Thank you, Miles. It's great to be here, and thank you for inviting me to Less Cancer's great workshop that you put together for addressing cancer prevention.
It's a pleasure. Let's talk a little bit about cervical cancer, HPV, and HIV. These are conversations which overlap, of course. First of all, HPV. Tell us a little bit about that. There is a high percentage of people, probably a surprising number to most, who at some time in their life will be exposed to the HPV virus, right?
That's correct. It's estimated that around 3 out of 4 individuals will carry HPV at some point in their lives. and most will not even notice it. It's a very highly prevalent virus, but it also transmits very easily. It's a sexually transmitted virus, but can also transmit through skin-to-skin contact and other means. But it's only in a minority of participants, minority of people who actually have the virus, that it has potential to progress and cause changes in the body that can lead on to cancer development. And cervical cancer is one of the more prominent cancers caused due to HPV.
So that is a stunning number, 3 out of 4. But as you say, mostly we don't have to worry about that. That said, HPV leads to an estimated 5% of all the cancers in the world. So it is something to reckon with, isn't it?
It is. And the amazing part about knowing and having the knowledge and the tools to detect as well as to prevent HPV is what makes this cancer really interesting from a public health point of view. I think it's amongst the very few cancers for which we know a obligate cause that causes those cancers, but it's also something that we have the tools to prevent them, both from a highly effective vaccine that can actually prevent the acquisition of the virus, but also methods to detect the cancer early through detecting the lesions that cause cancer and catch them at an early stage. So it is one of the leading causes of cancer-related morbidity and mortality globally. More than 600,000 women all over the world are detected every year due to cervical cancer. More than 300,000 of them die due to cervical cancer. That's almost 2 women every minute.
The numbers are actually quite stunning. Cervical cancer kills in excess of 340,000 women each year. Every 2 minutes, a woman loses her life due to cervical cancer. And let's make this as clear as we can. That's completely preventable, isn't it?
It is. And that's the amazing part. If we put all our resources and do all that we can in a concerted way, I think this is one cancer that we can safely say that we can actually eliminate over the next several decades.
Well, let's talk about the barriers, though. You can't just wave a magic wand in this world. There's all kinds of inequalities. And this is probably a poster child for the role of inequalities and disparities in health outcomes, I would say. Wouldn't you?
Absolutely. Cervical cancer is a cancer that is associated with individuals who have lack of access to healthcare. They are typically individuals with lower socioeconomic strata, lower educational attainment, or have other physical, geographic, financial, and other barriers that put them at higher risk for either acquiring the risk factor, but also at not being able to access the right care, either through vaccination or screening, that puts them at higher risk for the development of those cancers. And then there's also co-infections and comorbidities, such as HIV, that overlay on top of the HPV infection and increase the risk for individuals to develop cervical cancer over time.
So the HPV vaccine works, doesn't it? And is, first of all, when we think about vaccines on the tail end of COVID, although we're still in the middle of COVID, really, we think, first of all, about vaccine hesitancy. And also, frankly, during COVID, I'm sure people weren't getting to doctors the way they were. The rate of vaccines, is that returned to pre-COVID levels?
So in the United States, they have caught up to the level that they were prior to COVID. Unfortunately, the levels even before COVID were about 70% of all the target populations that we were trying to vaccinate, which is typically girls and boys between the ages of 9 and 15. But the vaccine, of course, is approved all the way till ages 45. It is certainly recommended for those who should take it between ages 9 and 26, but the emphasis is on adolescent vaccination. But due to a variety of factors, HPV vaccine rates and vaccine hesitancy associated with it only allowed the US rates to go up to 70 to 75%. And those rates have not certainly gone up post-COVID. And so we still have a challenge at hand to increase the rates for HPV vaccination, because this is one of the most cost-effective means to prevent cancer and therefore reduce the burden due to this disease.
Let's talk about why people don't get vaccinated for HPV. What are the hurdles? What are the obstacles there?
So a variety of hurdles have been documented, and we from the National Cancer Institute are supporting a lot of research to understand and also address how to overcome these barriers. One of those barriers is around both provider hesitancy and parent hesitancy around vaccination. HPV is, as I mentioned before, is a sexually transmitted virus. And so there were initial concerns that vaccination for pre-adolescents and adolescents would in the comfort zone of individuals in a pediatrician's office talking about a vaccine that's for an STD was significantly higher. But then people should also realize, and that's the messaging that is now underway through a variety of ways, that this is a cancer preventive vaccine. The virus may be sexually transmitted, but the actual target for this is to prevent cancer. And so overcoming the parental hesitancy, as well as facilitating means for providers to talk to parents and convince them about the need for cancer prevention that this vaccine allows, is something that a variety of organizations such as the CDC, the American Cancer Society, and the NCI are working collaboratively to address.
These are deep-rooted issues of belief and moray. It can be difficult to overcome these and kind of cut through, the kinds of disinformation that we've become familiar with. What's the best strategy to get that out there, to make it clear to people what this is really all about?
I think one of the ways to do this is to increase awareness. I think Less Cancer is doing a phenomenal job of putting the message across that there are cancers for which we can do something about. And I think increasing awareness both for parents as well as for the broader healthcare system that can actually increase access to providing HPV vaccines and reinforcing the messages around the role for cancer prevention potential for this vaccine and the type of cancers that can be prevented and the morbidities associated with those cancers that can actually vanish if somebody gets vaccinated early on with this vaccine could all be reinforcing messages that can actually enhance the efforts that are already underway to routinely incorporate this vaccine as early as age 9 that can actually increase the rates. And so I think there are several strategies that can be undertaken, but we'll have to work concertedly to achieving high vaccination rates upwards of 85 or 90% in the US. And so we still have some ways to go. The good news is we are already seeing evidence, which I think is also a reinforcing message, that cervical cancer rates are actually getting reduced in the populations that have been vaccinated. There is increasing evidence from Europe, but also there's increasing evidence about lowering of precancer rates and some early evidence of decreasing cancer rates in some of the youngest populations that were vaccinated since year 2006, when this vaccine became available for the first time, which is 14 years plus now, and has 16 years plus now, and actually has been showing its impact in terms of reduction of both HPV infection as well as reducing cervical cancer incidence rates in the populations that received the vaccine.
So the other thing to talk about here is screening as well, because with proper screening, you can nip this in the bud, so to speak. Tell us about that, and tell us what can be done to increase the amount of screening that's out there.
So great question, Miles, because cervical cancer screening is a life-saving intervention. It's better known as pap smears, which a lot of women in the US, about 70 to 80% of women are very much doing annual pap smears, or at least a better frequency of pap smears, going to their doctors, and has become part of routine healthcare. Unfortunately, the remaining cases of cervical cancer, which are about 14,000 cases in the US every year, half of those occur in women who are not screened for cervical cancer or are very infrequently screened. So we are trying to address some of these inequities for increasing the access of cervical cancer screening rates. And one of them is through person-centric approaches such as HPV self-sampling. This is an approach where women can actually collect their own samples in the privacy and at the time of their own convenience, and can actually send those samples to a lab for looking at the potential for detection of high-risk oncogenic types of the human papillomavirus HPV, which is a causative agent for cervical cancer. And if somebody is positive for that virus, that can actually serve as a marker for doing further investigations. The good news is we have those tests that are available, and we are working now with the FDA and with these companies that manufacture these tests to make this as a test that has a regulatory approval for using widely in the United States, that can actually increase access to screening for women who are either reluctant to get screened or have other barriers such as physical, financial, geographic, that can actually prevent them from seeing a doctor. There are several counties in the US where an OBGYN or even a family physician is not available for several hundred miles. And therefore, we do want to sort of go down that path of providing them screening at a place and time where it's most convenient for them, not letting the requirement for having a doctor's visit and a pelvic exam and a collection of a pap smear in a clinic be a barrier to achieving the type of screening that we need for reducing cervical cancer incidence rates.
Let's talk about HIV. A woman who is HIV positive, this further complicates the picture, doesn't it? Explain the nuances of that.
So HIV, or the human immunodeficiency virus, is a immunosuppressive virus, and therefore it reduces the body's immune responses and the ability for the body to clear several infections, including HPV. And so women who have HIV have a higher risk for the HPV virus to progress and cause cervical cancer. They're about 5 or 6 times as likely as women without HIV to have cervical cancer. And that is something that complicates both detection as well as management of cervical cancer in women with HIV, who form one of the highest risk groups, but also in most intervenable groups, because we already provide a lot of care for their HIV infection and keep them alive as a result of providing them antiretroviral therapy for HIV. And so how can we do better, particularly in low and middle income countries, but also in areas with healthcare disparities in the US, to actually improve and ensure that they have the access to life-saving cervical cancer screening tools? So through the National Cancer Institute, we have launched what is called as Cascade, a new network that is focused on improving cervical cancer screening and pre-cancer treatment efforts in women with HIV, because there's always a tendency to fall somewhere in this so-called cascade of linking screening, management, and treatment. And we are trying to address this burden both in low and middle income countries in sub-Saharan Africa, as well as in areas with fragmented healthcare systems in the United States, that can actually improve on cervical cancer screening, management, and pre-cancer treatment optimization, so that we can eventually reduce the rates of cervical cancer in this very high-risk population.
The numbers I see here are about 90% of new cases and deaths of cervical cancer occur in low and middle income countries. So that's clearly where the problem lies. When you try to address it with this program Cascade, how do you go about it, though? There's so many additional obstacles that you must face as you try to get through the barriers we've already talked about, which probably are augmented by other stigmas.
Absolutely. So we are working very closely with some of the on-the-ground individuals, organizations, as well as ministries of health in countries where we are launching Cascade, initially in 3 countries in sub-Saharan Africa, but also expected to move to other places globally, as well as in the US. Our emphasis is to identify the most opportune venues as well as expand the options to increase cervical cancer screening access by working very closely with individuals as well as organizations that cater to those who are affected and infected with HIV as a risk factor. And we are working very closely to improve their perceptions about getting screened, but also how can we increase the linkages between ensuring that those who get screened also get managed appropriately. So a screen positive result triggers a whole range of pathways, including going for a diagnostic exam called colposcopy or undergoing treatment with some methods such as ablation. And those are the steps that actually do not happen as a result of a variety of barriers that each present an opportunity for us to intervene. So it requires a whole of a village approach. It requires working with stakeholders across the spectrum. It requires close coordination with research entities, with public health funders, with ministries of health, as well as trying to enhance the capacity in the same places where the burden lies. Primarily, as you might imagine, there is a dearth of well-trained professionals. So we are also trying to increase access to screening by looking at approaches that can optimize the available healthcare manpower resource. So things like task shifting that allow us to transfer some of the tasks related to diagnosis or detection in the hands of non-physician healthcare workers like nurses that can actually overcome a critical barrier to providing the kind of high quality healthcare for these individuals in such resource constrained settings, if you will.
You've laid out a lot of challenges there, Vic. Are you reasonably optimistic you'll be able to get around all of that, plus add the language and cultural barriers and just the pure cost of trying to get the word out? Do you feel like you can make some progress here?
So, Miles, absolutely. I mean, this is certainly a huge challenge, and I've highlighted a few, but there are certainly a variety of challenges that I couldn't even talk about. I think the good news in some ways is this problem of being able to address the problem of cervical cancer, but also the opportunity to address prevention and control for cervical cancer is being recognized at the highest levels in both international as well as national governments. And so we do have a level of support. The WHO, for example, called for elimination of public health problem and increasing targets for screening to 90% and 70% and 90% of vaccination, screening, and pre-cancer treatment access by the year 2030. And therefore, we are trying to work with a variety of these stakeholders and taking advantage of the momentum that actually has resulted in the past few years. And also, I think as a result of seeing COVID in action and people realizing the importance of preventative healthcare, I think will probably help us in the long run as we try to handle this one of the more preventable cancers.
You know, I hope you're right. But I do think it's worth pointing out that historically, we don't fund public health very well, do we? What can we do to make sure that there is sustained funding and attention to what is required to maintain good, solid public health that is informed by good science?
You absolutely nailed it on the head. Public health is often the stepchild of health funders, and I think we do need to learn the lessons out of the COVID pandemic. It caught us, at least in the US, on a back foot of the ability to launch some of the more wide population level programs. Eventually, I think we all caught up with very widespread vaccination possibilities. But I think there are several areas in the US that are chronically underfunded in the field of public health. And I think we do need to make increasing awareness of policymakers, of professionals from the broader healthcare system, not just public health professionals, aware of the importance of an ounce of prevention, the proverbial ounce of prevention, and the ability for public health professionals to tackle that potential. Why can't we sort of invest at a fraction of the cost and making the health economic argument, for example, for reducing the burden, as opposed to a lot of the efforts that and the cost implications for a curative argument that continues to dominate the healthcare system in the US, and certainly globally. As you know, it's absolutely a huge challenge. It's not insignificant challenges to prioritize public health amongst a whole range of other conditions, particularly when economic conditions globally are not stable. I think it does need every bit of us doing everything possible to increase the type of awareness that's needed.
I can't think of a more poignant case in point and argument for investing in public health than hearing that every 2 minutes a woman somewhere in the world dies unnecessarily. That's such a sad statement.
It is indeed. And one of the huge underappreciated facts about cervical cancer, which I think is very increasingly recognized, is the women who die due to cervical cancer are often in their 30s, 40s, and 50s. And they leave behind not just the challenge of their own death, but a whole range and a whole generation of orphans who are going to grow up without their mothers around them, and they're going to grow up in families without a caregiver, without a income provider. And I think this causes destabilization in societies, or it has the potential for destabilizing families for certain. So the effects of cervical cancer are profound, and they are obviously we do think of the individuals who get cervical cancer and who die from the disease, but I think it's a huge problem even beyond that, and the whole intergenerational impacts that cervical cancer creates are also something that we should try to emphasize.
Dr. Vik Sahasrabuddhe, thank you so much for your time, and thank you for your service to public health. We appreciate you being a part of the National Cancer Prevention Workshop, John Dingell Cancer Health Disparities Access Interviews. Keep up the good work.
Thank you so much, Miles, and thank you for all you do for increasing the awareness on the Hill and elsewhere to keep up with the huge challenges that we face in in preventing cancer. So thank you for the National Cancer Workshop organizers for having me here. Appreciate it.
You're most welcome. Welcome back to the National Cancer Prevention Workshop, produced each year by the organization lesscancer.org. We are continuing our John Dingell Cancer Health Disparities and Access interviews. And today we're talking about some causes of cancer which you may not be as familiar with. Joining us is Dr. Gregory C. Townsend. He is an infectious disease specialist at the University of Virginia Medical Center. And Dr. Townsend, first of all, good to have you with us.
Thanks for inviting me. Glad to be here.
Okay, great. Well, I know people are familiar with the genetic causes of cancer as well as the environmental factors, whether it's smoking or drinking or putting on sunscreen. There is a whole host of infectious agents which cause cancer. First of all, is there, just so maybe I wasn't paying enough attention, but is there growing awareness of these infectious agents and their connections to cancer?
Yeah, I certainly think that, well, in the world of infectious diseases, we've been aware of many of these connections for a long time, but I think it's becoming more apparent to the general population that there is a connection between some cancers and or between some infections and some cancers, and that there's an increasing interest in researching possible connections between the two fields.
So let's talk about what's actually kind of under the hood here. Is it as simple as infections, can create inflammation or compromise your immunities, or is there some sort of chemical way an infection can actually trigger cancerous cells, or is it all the above?
All of the above. That's a great question, Miles. So in some cases, so like an example would be hepatocellular carcinoma. So we know that hepatitis C and hepatitis B viruses, which affect the liver, can lead to hepatocellular carcinoma. But it doesn't look like in those circumstances that that the viruses are causing like a genetic transformation in the liver cells that causes the cancer. It appears that it's inflammation in the liver, when there's this constant stream of degradation and reconstitution of the cells, which leads to increasing likelihood for mutations to occur, and that's what causes the cancer. Compare that to the case of human papillomavirus and both genital cancer, so cervical cancer, vulvar cancer, penile cancer, and now it's one of the more common causes of esophageal cancer. And in that case, it appears that it actually is the virus that is causing a genetic transformation in the cells that leads to the cancer. So it can be either mechanism that is occurring.
So it's complicated, and but it seems like this is the kind of thing that if you're screening for the initial infection well and treating it, this can nip a potential cancer in the bud, or is that too simplistic to say?
Oh, absolutely. That is, that's why we do cervical cancer screening, right? We are looking for changes that suggest that these cells are infected with human papillomavirus, and we can actually do a genetic analysis to look for specific strains of the human papillomavirus that are associated with cancer. And if we find that there are evidence that suggests that the cells are infected with the human papillomavirus, carcinogenic strains, then we can take the steps appropriate to try to get rid of the tissue that is infected. So screening is absolutely essential to try to reduce the likelihood that someone is infected with one of these cancer-causing viruses, can then reduce their risk of developing cancer.
And of course, in the case of HPV, there is a vaccine as well. So this is a case where a vaccine could prevent cancer in a sense.
Yeah. The first and only cancer preventing vaccine. I just think that's a huge step in medical progress. So we have a vaccine against cancer is just tremendous.
And yet, I believe, what is it? The numbers are they about 70% who receive the vaccine?
Okay.
That's not good enough, is it?
It is not. No, it's not great. And there are certainly many reasons that people may defer deliberately getting the vaccine, often for religious reasons. But there also, unfortunately, are social determinants of health that may restrict someone's access to the vaccines. And so we have individuals who are at risk for developing these cancers who shouldn't be because vaccines are available.
Yeah, I believe there are more than 300,000 women a year who die of this the world over. I think a woman dies every 2 minutes of this, which is it's completely preventable. And I know as much of a problem as it is here in places like sub-Saharan Africa, it's really a huge challenge to get the word out, isn't it? Because there's so many mores and stigmas associated with this one.
Right. Yeah. And people have used the excuses that if you give someone the human papillomavirus vaccine, well, that's just going to encourage them to engage in sex, because now they don't have to worry about getting cancer, which is just it's a specious argument, and it's a frustrating one to have to try to counter. But again, there also are problems with cancer or rather vaccine delivery, particularly in areas of resource limited areas, both abroad and in this country.
Let's talk a little bit about HIV and cancer. In this case, you have a compromised immune system. Is that the real root cause that leads to problems with cancer with HIV?
Right. Yeah. So we are protected from cancers by our immune surveillance system. Probably most of us at any one time have some cancer cell pop up here and there, and our immune systems, recognize it and attack it and get rid of it before it can cause any problems. But with HIV, our immune systems aren't, people have advanced disease. Immune systems aren't working as well as they do. They don't have the capacity for performing adequate immune surveillance. And so when a cancer cell pops up, it has time to gain a foothold and to multiply and divide and to form a malignancy that can cause a problem. So one of the things that we are very aware of in HIV care, and there are certain cancers that sort of associated with HIV, like the Kaposi sarcoma and cervical cancer, which are much more common in people with HIV. But the reality is that almost every cancer is more common in people with HIV than it is in the rest of the population.
Boy, talk about collateral damage to a horrible disease already. So has anybody, presumably you would know this, the number of infectious agents, we're talking viruses, bacteria, parasites, tallied up the number and the number of cancers that are connected? Is it a bigger number than we think?
So in the human population, there actually aren't a lot of infectious diseases or infectious agents that are strongly associated with cancers. There are a few that we have talked about. There are actually many more in the animal world. One of the first evidence of viruses causing cancer came from animal studies looking at a sarcoma virus. But there are sarcoma viruses in the human population that can cause sarcomas, which are soft tissue viruses. So there aren't a lot of them. It's not in the millions, but there's certainly enough to be problematic.
So is there an issue of public awareness here? Do people need to be more dialed into how these infectious agents can lead to, much more serious consequences potentially?
Yeah, and again, I think one of the important messages here is that we can do something about this. So again, the case we talked about cervical cancer and how it's so very, very important to get screening. And I should mention, not just cervical cancer, but also anal cancer. It's important to get screening for that for people who are at risk from HPV-associated cancers, but also things like hepatitis B and hepatitis C. There are an estimated 1.5 million people in this country who have hepatitis C infection who don't know that they have it. And this is a disease that, if left untreated, and we have treatments that are 97% effective. We don't have a lot of treatments available for anything that are 97% effective, but we can get rid of this virus, done, gone, killed 97% of the time. There's no reason anybody should be walking around with hepatitis C in this day and age. It is encouraged that people who are in certain risk groups get screened, and we should be doing that. We should be emphasizing them. And if someone feels like they may be at risk, they should be talking to their healthcare provider, saying, I need to get a test for hepatitis C. I want to make sure that if I know that I have it, I get treated for it.
Yeah, almost everything you mentioned here, or frequently, there are great ways to stop this. And as you say, for whatever reason, whether it's just lack of knowledge or stigmas or whatever, we're not getting there. That's particularly poignant, particularly when you're in your line of work, to hear that, I imagine.
Yeah, it's an interesting. So my field of specialty is infectious diseases, and one of the things that is very clear to all of us in this field is that infectious diseases tend to be diseases that disproportionately affect people in marginalized groups, people who are poor, people who have poor access to healthcare for a number of reasons, some of which may be social stigma or economic issues, and that sort of as a cross section of individuals with cancer as well, that these tend to be more common among individuals in resource limited settings, individuals who have difficulty accessing healthcare, and not just more common, but unfortunately have increasing morbidity and mortality related to the cancers in those groups.
Well, we've got to figure out a way to make healthcare more accessible to broader numbers of people in this country. In this We have such tremendous wealth in this country. It's kind of stunning to me that this happens.
Yeah, that's certainly one of the more frustrating things that I have to deal with on a regular basis is that we have the best healthcare system in the world. I have no doubts about that. What we have problems with is getting people access to it. And again, there are so many reasons that people may not have access to the healthcare system that we have. And that's in this, the 21st century, there's no reason for that.
Agreed. And I want to shift gears slightly. I know infectious diseases, your sort of your main day job, but you also are the associate dean for diversity at the medical school there. And I know one of the issues when you get into the issue of screening and prevention is the issue of prostate cancer, and in particular among African American men. Disproportionate numbers of them face prostate cancer.
Yeah.
Do we know enough about why that is yet?
Well, so there's probably a genetic component to it, but I think there's also, again, there are problems with access to screening that may lead to the development of prostate cancer in individuals who might not otherwise have developed it. And then, as I just mentioned, that individuals, blacks who do develop prostate cancer are more likely to die from prostate cancer than are whites in this country. Social determinants of health. It's interesting. I mean, I'm so very glad that healthcare personnel who are being trained today are being taught about social determinants of health because they are so very important. I just saw a slide not very recently that showed sort of the breakdown of how different factors affect our healthcare, our health rather. And only about 10% was genetics and about 10% was medical care, and the rest was social determinants. That's where we need to be focusing our attention. That's a very, very fixable problem.
Was this overlooked for a long time? And if so, why do you think that was?
Yeah, I was giving a lecture to some visiting fourth-year students about social determinants of health a couple of weeks ago, and I told them when I was in medical school, which it was a while ago, but within the last century, I literally never heard the phrase social determinants of health. I don't remember ever anybody talking about how, where someone lived, how much money they made, their education, how any of that affected their health. So yeah, things have changed, I think, much for the better in terms of the education that our healthcare trainees are getting. I think we have a lot of work to do in terms of actually addressing the problem. And then, there was an Institute of Medicine monograph that came out almost 20 years ago now called Unequal Treatment. Where they looked at a number of different domains of health and tried to figure out, why it is that there was a disparity in health between blacks and whites in this country. And the conclusion was, even if you take into account socioeconomic status, there are still these disparities. So there's something about how people are being treated in the healthcare system that is leading to these disparities in health.
Well, I guess, the first step is acknowledging the problem. So maybe we've taken that first step, but there is a long road ahead, isn't there?
Yeah. And, again, I think there are a lot of people who are looking at this and thinking hard about it. Frankly, the Affordable Care Act was a huge step in the right direction because it gave, tens of millions of people greater access to healthcare that they wouldn't have had otherwise. But we still have a lot of people who are uninsured, underinsured, or live in areas where they have difficulty getting access to healthcare. We have a profound shortage of primary care providers in this country who act as the gateway to make sure that people are getting the health care that they need. So we have a lot of work to do to make the promise of the best healthcare system in the world work for everybody.
That's the fundamental irony there, isn't it? It is the best healthcare system in the world, just not for everybody. And the inequalities of that, we shouldn't allow that. We shouldn't allow that to continue, should we?
No, we really shouldn't. And there are obviously there are forces at play here that are above your and my pay grade, that are working on both sides. Some trying to make sure that we have better access, and some who feel like we'll let the forces of economics play out and hope for the best. Let's hope everybody gets better. It's working.
I don't know that we can ever have a system that is for profit and still is patient centric. I think those things probably are difficult to reconcile.
I think they're impossible to reconcile. I don't see how you can have a system that is built on because the insurance is built to not give out money. They don't want to have to give people money. They lose money by doing that. So a system that is built on private insurance system is not going to be providing the best care for anybody. Well, except for those who have a lot of money who can afford the best private insurance.
You've hit the nail on the head. And that's pretty much it in a nutshell, isn't it? I mean, it's a big, complicated story, but that really is it, isn't it?
Yeah, and I can't tell you about the struggles I've had with insurance companies recently about trying to get. It took me, literally took me 3 months to get one of my patients an antibiotic because their insurance company didn't want to pay for it. And I tried to point out to them over and over again, look, you're either going to pay for this antibiotic, you're going to pay for the hospitalization. You decide.
But that's the system we have. We don't believe in prevention, right? We wait until the house is on fire.
Exactly. Yeah.
All right. Well, I don't know that we've solved any problems, but we certainly highlighted them, and I guess talking about them is part of it. So
raising awareness is the first step. And again, I think it's very important for people to understand that we have these issues and that we have solutions to the issues.
Dr. Greg Townsend is an infectious disease specialist at the University of Virginia Medical Center. And I thank you very much for your time and for joining us on the John Dingell Cancer Health Disparities and Access interviews this year. And keep up the good work, will you?
Thank you again. And again, thanks for inviting me. It was a pleasure to be here.
Our pleasure. Welcome back to the National Cancer Prevention Workshop, produced each year by lesscancer.org. I'm Miles O'Brien, chairman of the board of Less Cancer. We're conducting a series this year we're calling the John Dingell Health Disparities and Access interviews. And we're talking about disparities and their impact in particular on occurrences of cancer as well as cancer deaths. Today, we're going to focus a little bit about disparities in rural communities versus urban settings with someone who knows an awful lot about this. Jan Carney is at the University of Vermont Larner College of Medicine. She is the Associate Dean for Public Health and Health Policy. She's a longtime friend of Less Cancer, and she's here now to talk with us a little bit about the differences between rural and urban settings and how that affects outcomes when it comes to cancer. Jan, great to see you. Thank you for joining me.
Thanks very much, Miles. It's great to be here.
So, Jan, let's talk about what's going on rural versus urban. Can we say, are there categorical statements we can make about the health of a rural population versus an urban population? Now, those are two giant buckets, but can we say, generally speaking, people in rural settings are not as healthy, or is that going too far?
I think that's too broad. Let me just, I sum it up as place matters. Where you live is a very important determinant of your health. Health is determined by zip code, probably more than your genetic code. And so people who do live in rural areas, particularly with regards to cancer, there are differences in their health. And those are for a variety of reasons that I can tell you about.
Well, let's talk about that first. Let's talk about, before we get into the kinds of treatments they may or may not be able to access, which is an interesting thing to talk about. Let's talk about what's causing all of this. We could run through the list of tobacco and alcohol and obesity, but so let's walk through it. What's at the top of your list when you think about what's causing more incidence of cancer in rural settings?
Sure. First of all, there are two things. First is whether there's more cancer or whether people there's more deaths from cancer, or people don't have access to early treatment, preventive care, and health care. And those factors are both very, very important in this. If you think about it, it's a factor of both health care, those habits and behaviors, and access to preventive screening that can be life-saving. All of those factors may differ whether you live in an urban or rural settings.
So, all right, let's walk through tobacco use, for example. I know in Vermont, there's a pretty high tobacco usage percentage, right? And is that there's probably a million reasons that cause that, but are the public service messages not reaching some of these communities, perhaps?
Well, for example, step back maybe and look at all habits and behaviors. Okay, in rural settings, you're more likely to see an increase in habits and behaviors that may be related to later risk of cancer. So tobacco use rates may be higher in rural areas, alcohol use rates, obesity rates, and less access to HPV vaccines, all of which may be related to later development of cancer. Here in Vermont, overall, I think we're doing really well in terms of adult tobacco rates. But your question as to, is it as easy for people to get access to cessation help for that, or even get a medical appointment in a rural area to get advice about that or counseling? No, it's much harder.
So there is a component of, health and medical literacy here that is important, isn't it?
Yes, health and medical literacy is very important. And that is actually one of the things we're trying to do. We're trying to improve health literacy in our rural parts of the state and we've learned quite a lot by studying differences in rural health communication and how people in rural areas want to get health information. People here in our urban areas want to use the internet, and they might watch TV. People in our rural areas want to use word of mouth and Facebook, and are more likely to want things from their town paper. So if we listen and pay attention to that, that will help us for the future in terms of getting some of those educational messages out that people need to help prevent cancer.
That's a very interesting demographic insight. Is that a function, you think, of age, or is it a zip code issue, or you could make a case that that's generational, I suppose?
Well, it's not really related to generation in entirety. We certainly know that we have one of the oldest populations here, but it's sort of, we've been studying this from a variety of different directions, and it seems to be a consistent finding. And I think it relates to how our communities are structured. So people in our rural communities might rely on their town clerk. They love their town paper. And so, thinking about if that's what people are paying attention to, then for us, it's on us to put the health information in the places where they would like to read it or see it.
I suppose it's worth a couple of words here about obesity and its links to cancer. It's really in the loop on several cancers, right? Tell us a little bit about that, what obesity means for cancer incidence and ultimately mortality.
It's about, basically, I think there's CDC says there's 13 cancers that are of higher risk related to obesity. So in terms of habits and behaviors, the more we can help people be physically active, obviously the better we'll do in preventing obesity and all the health conditions, all the chronic conditions that relate to that, diabetes and cardiovascular disease, as well as cancer. But in the rural areas, it's harder. And I guess the visual picture I use is we have something called mud season here, and we talk about when the snow melts and before summer, and some of those rural roads get really muddy, and it's hard to get from place to place. And so think about those actual physical barriers, or if you might live in one of those areas that you might not necessarily have a place to go to be physically active, or even if you do, it's harder to get there.
So it's difficult to be more physically active, particularly at those shoulder seasons, but also the diet itself. We talk about food deserts when we're in cities.
Yeah.
Do people in rural settings, on the one hand, you can imagine an agricultural community, you might think intuitively, oh, they probably eat well, but maybe not necessarily.
Well, Miles, I think some of the ways I think about it is step back and think about social factors in health, and all the ones that impact people. And people who live in rural areas might have more trouble with a higher paying job, getting a higher paying job, or on the average, and this is not universal, but on the average, might have less educational attainment. We know that transportation is definitely an issue. We know that they have difficulty getting to healthcare. There may not be enough people providing healthcare in rural settings, and we need to do better with that, across our country. And so there's just many, many reasons why it's harder for people to both know the kinds of things that they need to do to keep themselves healthy, have the resources to do that, including health insurance, have the transportation, have somebody to go to, and then have the availability of cancer screening services, as an example, in their own community, so that whenever they can get time off, they're able to access those.
Let's talk a little bit about the role of health insurance in this mix. What percentages are we talking about of people who are not covered, even in the wake of ACA? We still have a lot of insurance that is linked to people's jobs, right?
Right, exactly. In our country, that's the biggest association is we get our health insurance depending where we work. And so depending on what your job is and whether or not that's a part-time or full-time job may determine whether you're eligible or to enroll in health insurance. All right, so even if you're not, say, we know that healthcare costs a lot. So the costs of those premiums for yourself or your family may make it very challenging, again, depending on your job. And then in terms of complexity, we think it's a high cognitive load to try and go on the websites and figure out what you're eligible for, how to get those subsidies that are more and more available. So bottom line, in my view, we've done a great job through the ACA expanding access. It's still, we don't have universal access. That's a huge barrier in our country. And that's a top priority that will help us in health across the board. It will definitely help us do better in terms of cancer prevention and treatment.
I mean, if you could wave a wand and create universal care for everyone, do you think that would have a huge impact on what we're talking about here?
I think that would be a huge impact, but not enough. And the reason I say that is because healthcare is one of a number of factors that are necessary together for us to be healthy. And so we've already talked about some of those, and those are our habits and behaviors. Do we have access to healthy food? Do we know what foods are the best to eat, for example? Do we have a place and time to be physically active? Do we never smoke, or if we are smoking, quit smoking and have access to resources to help us? And do we have someone to go to? Is there a place, a medical home? Is there a place we can get healthcare so that we can get primary and preventative care, and that there's somebody besides us being responsible to tell us, you're this age, you should be screened for colon cancer, for example, if you're 45 years old, or if you're younger, for cervical cancer, or a mammogram if you're a woman, those sorts of things. And it's the total package, in my view.
Well, you mentioned HPV earlier. You just mentioned colorectal. Why the disparities on screening?
Well, because in terms of rural access, and I would go back, let's use colorectal cancer screening and the availability of that. If it is harder to access healthcare in rural settings, why is that? There may be fewer doctors and nurses. It may be harder to get an appointment. It may be transportation may be a huge issue on an ongoing basis. So you may not get to go as often. So then there's that factor. And then if you're in a smaller area, how close is the facility? If you're going to get a colonoscopy, for example, that is likely not done in your doctor's office. But you can have access to another form of colorectal cancer screening. So having those regular checkups and having those recommendations and being able to actually get that care for colon cancer, much harder in rural areas.
Let's talk about the overall quality of care in rural settings. Generally speaking, people in rural settings have access to smaller facilities. And I know you've talked about the idea that high volume hospitals are linked to better outcomes. That's a difficult problem to address, isn't it?
Well, it depends what you're talking about. So in terms of primary and preventative care, I think that individuals, whether in rural settings or academic settings, who are well trained and credentialed and have the appropriate state and local credentials, and provide, and we have metrics by which we can measure quality, whether you're in a rural setting or not. So I don't necessarily think that in terms of the care that most people need to keep them healthy, primary and preventative care, we can have outstanding and high quality care in rural settings. But we have to make sure that we have the right incentives to get the doctors and nurses who are in training out there. We have to provide the community support so that they will stay there. And then we have to help people understand how to get an appointment and have enough people that they have someone to see.
Are there disparities, though, taking individuals who have cancer, for example, all things being equal, urban versus rural? If you're in a rural setting, are you more likely to die?
The survival across the board for all cancers is worse in rural settings. All right. And those are specifically both the amount of cancer, the incidence of cancer, and death rates for tobacco-related cancers in particular are worse in rural settings. So we can pay attention to those, for example, lung cancer and access. We can come back to why that might be. And then for some areas in rural settings, the screening is harder. And we've talked a little bit about that. It's challenging to get there. It's challenging to make sure that you have enough screening services. So what we have to do is figure out ways to connect those patients in the rural communities to the state-of-the-art cancer care. So those connections between rural primary care and the tertiary centers, making sure that the physicians and nurses in those settings are aware of the state-of-the-art treatments available, and particularly the clinical trials. That's really, really important, and that patients are aware. And those are some of the activities and things we're trying to prioritize with our rural health communications. Are there ways, and we don't have all the answers yet, are there ways to help people in our rural settings enroll more easily, for example, in a clinical trial? I think there's a lot to be done. I think there's a lot more that we can do with the evidence and the practices. I mean, there's lots of things that we already know that work to help this, and applying those in our rural settings. I think there's a ton more we can do to help people.
Yeah, I'm hearkening back to your description of mud season, for example.
Yeah.
If someone in rural Vermont needs to get to Mass General, that can be a real challenge.
It could be. Yeah, but you might not, for the vast majority of your treatment, you might never need to even consider that. You know, we have outstanding medical facilities right here locally. We have a tertiary medical center here at the University of Vermont Health Network. That covers much of upstate New York and Vermont, and down for people living closer to the Hanover area, we have Dartmouth Hitchcock Medical Center. And so we have two tertiary centers right here that really can help most of the people locally, for the most certainly for all of the cancer screening tests and for much that's needed. But in some ways, it's a matter of helping people to know what they need and helping them to get there.
So you talk about the differences between equality and equity. I'm curious if you could help people understand that. That was a nuance that I really found insightful.
I guess one of the best visual examples that I've seen recently has been think about the difference between equality and equity if a variety of different people had a bicycle. So everybody gets a bicycle, but if you're a child or you're someone with physical disabilities, you probably can't ride that one. It's not the right size for you, or it's not the right frame for you. So equality would be, yep, you got a bicycle. Equity would be, you have one that you can actually use. So you have the opportunity to ride that bike. So think about the ones that are fit for kids or for people with physical disabilities that you see people using. That's the difference.
So when it comes to healthcare, particularly in rural settings, the march toward equity faces a lot of challenges. Are you optimistic?
I am optimistic. We have a lot of evidence. There's quite a body of evidence that, in the clinical side, we have the Clinical Preventive Services, U.S. Preventive Services Task Force that gives us the evidence-based recommendation for what you need. That tells us what works. If you follow that screening, you're more likely to prevent cancer or less likely to die from it if it is found. Really, really important. Now, getting that to everyone is trickier. And there's another body called the Community Preventive Task Force, or the Community Guide, that provides evidence-based recommendations for people living in communities, like what works in a community setting. Things like community health workers. These are non-medical professionals that help link people to services. I think there's some great evidence for things that we could do if we applied more systematically all across the board, in our rural settings. Health literacy, we talked a little bit about that. If everyone knew what are the specific healthcare services, what are the health behaviors, what are the priorities for their own health that over a lifetime could help them, that would help a little bit too.
I think a fair number of professionals will be listening to you here, and aspiring professionals. What is your pitch to them? If nothing else, I think you probably need a lot of expertise willing to live in these places and serve this community.
I think that commitment to health is paramount. In terms of health outcomes, place matters. And I think we can do so much with what we already know without any additional research. And the way I think about it from a public health perspective is in something that's really common, like cancer. If we can have even a small impact in a very common public health problem, we can help many, many people. That would be my message. And that is the most rewarding thing I can think of to do.
Great insights, Jan Carney. Thank you for your service to public health, and thank you for joining us on the National Cancer Prevention Workshop. John Dingell, Cancer Health Disparities and Access Interviews. A mouthful, but lots to talk about in just this past 20 minutes. Thank you very much.
You're welcome. Thank you, Miles.
Welcome back to the National Cancer Prevention Workshop, produced each year by lesscancer.org. I'm Miles O'Brien, the chairman of the board of that organization, and we're continuing our discussions we call the John Dingell Cancer Health Disparities and Access Interviews. And today we're going to talk about health disparities in the context of rural settings with someone who knows an awful lot about that. Rob Marino is the executive director of the Fauquier Free Clinic outside of Washington, D.C., Warrenton, Virginia. And this is an organization that for about 30 years has providing free healthcare to those in need in that community. Rob, good to have you with us.
Great to be here. Thanks, Miles.
Rob, tell us a little bit about Faukier's Free Clinic, how it all kind of got started, and what gap it attempts to fill in that part of the world.
Well, the free clinic started, I think, in 1993, a little before I was with them, in order to bring healthcare, dental care, and eventually mental health care to low-income families here in Fauquier County and Rappahannock counties in Northern Virginia. At that time, physicians and dentists in our community were seeing a lot of patients who couldn't afford to pay, or even if they were willing to see them for free, they would find that they didn't have access to x-rays and diagnostic services and medicines. A lot of children who weren't getting access to care. And so it became kind of a grassroots response to a local need. And we've grown and grown ever since then. And now we have a 5-day-a-week multi-specialty clinic that still doesn't charge any patients any money for healthcare. It's a pretty great thing to be associated with.
So before this existed, the folks you see in this office, where would they go to seek health care?
Either nowhere, I think, was often the answer, or to the emergency room. And as you can imagine, that's a pretty terrible way to get your health care on a regular basis. And so it really wasn't working. And, this is a nationwide problem, but it was pretty acute in our community. We're in sort of a rural outskirts of DC area where there are not a lot of other services and folks have to travel a ways to get help.
So this is a crucial gap that you're attempting to fill. To what extent do you think you're reaching everybody in your community who has this need?
We've come a long way. There's still plenty of folks who I think wait too long or find it too hard to get help. But we are up to about 2,000 people a year that we're able to reach. And some of them have pretty complicated and difficult problems. So we see them quite a few times a year. So we're making a big difference in our community, the size that we are. But certainly we're not satisfied.
You've got unprecedented demand, as I understand it. What is driving that? And is this perhaps related to the pandemic?
The pandemic hasn't helped, of course. But folks in our community, there's a pretty wide range of incomes and family situations. And the people at the bottom are left out, just like in any other situation. Getting access to preventive care and things that don't feel like an emergency. If you don't have disposable income, that's not something people elect to do very often. So we really have to make sure that that's available and do outreach and kind of explain and share and teach and welcome folks so that they come in and be a part of their own healthcare.
Give us a sense of kind of a typical scenario, a typical kind of patient that you see and how you address these issues.
Well, our typical patient, there are a lot of different kinds of folks. We see adults and children. A typical family is struggling with obviously a lot of financial pressure because that's what we're all about. A single mom, might be a kind of a typical patient for us. Lots of adults ages, 30 to 50 who have all kinds of healthcare needs, dental care needs, and, more and more lately, mental health care needs. That there's just not a lot of options in our community, even if you have money and insurance, but of course, especially if you don't. So we're helping people with asthma and depression and high blood pressure and screening tests for cancer like pap smears and mammograms and making sure that those things are happening. Dental care and, from emergency dental care to preventive dental care. And then, whatever counseling and support we can help people with, that's what we're doing.
And this is something that is funded entirely based on charitable contributions. Is that how you keep things going?
That's the right question. We do have a lot of local support, financial donations and charitable contributions. In January of 2019, Virginia elected to expand Medicaid for adults. And, before that, none of our patients had any kind of payer at all. Now about half of our patients are completely uninsured and about half have a Medicaid payer. And so we do get a little bit of money through the Virginia Medicaid system. But it is mostly local foundations, families, donations, fundraisers, that kind of work.
It's on the one hand, it's heartening to see this. On the other hand, it makes me sad that we need this in this big, beautiful, rich country we have. What are your thoughts on that?
Well, I feel the same way. We live in a pretty wealthy part of Virginia, in one of the wealthiest parts in the country. And yet there are thousands of people who are left behind. About 1 in 10 people in the counties that we serve is completely uninsured. And our eligibility process, we do some screening to make sure that we're reaching the right people. And we see folks whose income is under 200% of the federal poverty limit. So for a family of two, that means that they're living, probably under about $35,000 a year in household income. Our average patient is living on about $12,000 a year. And in this community, that's not enough, to take care of your family needs and also buy healthcare. No one can buy healthcare given what it costs.
Not by a long shot. Should there be further expansion of Medicaid, or let's take it a step further? Should we just have a big single payer system where healthcare is viewed as kind of a fundamental right.
Well, certainly I agree with the sentiment. Our whole reason for being is that no one should be left out. It is a human right. It hurts all of us when the least of us are not taken care of. I will say that expanding Medicaid in Virginia has led to lots more access for people. It's still not enough, and like I said, there's 1 in 10 that still haven't been reached. But you can see the impact it has made. It has helped us to get services for our patients. Sometimes they can come to us, but what they really need is a specialist, or they need to be sent somewhere for some more advanced diagnostic services. If they have a payer, that's so much easier, and Medicaid can be that payer. Otherwise, I don't know. We're at the sharp end of the stick. We see patients, one at a time and try and take care of them. But from a policy point of view, if people have access to the system, it's obviously dramatically better for them.
So one of the things which I really like what you're doing here is you're trying to bring all these siloed specialties or disciplines kind of under one roof. We tend to, in this country, put kind of classic healthcare in one silo, and then dental care, for whatever reason, is viewed separately, even though it has direct impact on our health. And then, of course, mental health, which impacts everything as well. All of these are kind of treated differently with different specialists, and it is infrequent that it is all viewed in one ball of wax. Talk about why you think that's important.
Well, for our patients, just coming into the clinic in the first place is a reach. Transportation can be hard. Maybe the family, there's a lot of people sharing one vehicle, and it's needed for somebody to get to work. So when we get somebody in, we really take that as an opportunity to do everything we possibly can. Every time we send someone off to go to a specialist or to get some other service, some of them drop out, like they just can't complete that step. So if we get them in, they're seeing our physician and they're talking about, I can't sleep, I'm uncomfortable. And it becomes clear that that's because of anxiety, or perhaps it's because they have dental pain and they're not sleeping. We can walk them down the hall and introduce them to one of our other clinicians and try and take care of it before they leave the room, or the building rather. That's night and day for what the patient experience is, because like I said, once we lose them, sometimes we don't see them again, and you've really missed a big opportunity to take care of somebody with what was really the root of their problem.
Why doesn't our system take a more holistic approach? And I'm talking kind of writ large here.
Yeah, that's a complicated question, but like everything else, it kind of comes down to money. When you look at I have health insurance. Separately, I have dental insurance. My experience has been that dental insurance doesn't usually do what people think it will, or it doesn't pay very well. But the fact that it's separate in the first place just leads to a splintered system, right? I mean, you can't take your health insurance card and go to a dentist. And, we kind of forget that that's what was behind the whole separation of these services, but it is. I don't know if you have liver disease, people have a telethon and you can go see a specialist and talk about your liver, but if it's your teeth, it's completely separate. And people don't tend to think of it as healthcare, which is a shame, because it absolutely affects your health and your well-being in a very dramatic fashion.
It's kind of stunning to me, because an infection which begins in your mouth can have a devastating impact on your health.
Absolutely.
And I know recently you did focus on this with an event you called Piedmont Smiles. Tell me a little bit about this, because I always marvel at whenever free dental clinics are set up in places like Appalachia, the amount of people waiting in line with horrible, painful mouths is stunning.
Yeah, thank you for asking. We had never done this before, but recently we did set up one of these kind of crash one weekend dental events, because we have a dental clinic in my clinic is full weeks and weeks out to get an appointment, and we're working as hard as we can. There just isn't enough capacity to help the amount of people that need it. So we partnered with Virginia Commonwealth University and Howard University and the Virginia Dental Association Foundation. And we took over a local high school and used their 2 gyms and set up a mobile dental clinic for a couple days. I arrived at 5:15 in the morning in the dark, in the cold, and the line was around the building for folks waiting to get free dental care. 12, 13 hours later, we were still there finishing up with the last people. Those folks had waited that entire time. They were there in the dark and the cold, and they were there all day to get dental care. You said before, it makes you sad. That makes me sad, that people have to wait 12 hours to get really what was emergency dental care here in this country. But it was pretty inspiring to see the dental students and the local dentists and all of the folks who pitched in together to make it happen, allowed us to help more than 200 people in one go.
It's just stunning to me that in this country that happens. It really is. I sort of can't get over it. I don't. And it's interesting, no matter, even in all the conversations, ACA and you look at Medicare, dental is still partitioned off as a separate operation for some reason.
Of course, that's true. And, I feel the same way about mental health care. Somehow it's considered separately from healthcare. I think we've made some progress in awareness for folks, but all of these services need to be available to anybody or they can't be healthy.
As you do your work, I'm sure you get great gratification out of helping individuals, but is it difficult to remain, optimistic overall?
I have my moments, but I get to work with people who have chosen to work in this way and for these patients, and that's pretty inspiring. Look at that dental event. Nobody was getting paid. Those folks were there working on their feet all day to try and take care of a need. I couldn't talk them into taking breaks or getting lunch. Like, no one wanted to stop. So, you see what capacity we have and the kind of people that want to do better. I get some hope from that.
Ultimately, and I should have mentioned at the beginning, you are also a board member of Less Cancer. This organization is about reducing cancers, and this is exactly, these individuals, if they can't get preventive care, it is often the case that they end up walking down the path toward developing cancers for various either environmental or exposures to bacterium or viruses, and or just not screened properly. Do you feel like clinics like this, do a good service, but are enough?
I think it's a step, but the patients that we serve, the way that they access healthcare without us is they wait, they go to an urgent care when they have had the flu or something like that, or an ear infection or a fracture, they go to the emergency room. And that's the only way they access the healthcare service. It's episodic, it's late, and there's never a primary care relationship between a clinician and the patient. And if that's the only way you use the healthcare system for years, then the opportunity to get recommended screenings is gone. Nobody is talking to you about that. And so when you do finally have an issue, it's found much later. It's progressed, it's harder to treat, it's more expensive, it's more devastating for you and your family. It's just no way to take care of people. We've just really gotten into this bad spot where prevention and looking ahead and screening and trying to catch things and teach and talk about lifestyle, all of that is happening way too late in the process.
So, Rob, how much are you able to, either encourage or provide screening, or at least send some of your patients to get the kind of screening that would be helpful in a preventive way to keep them from developing cancers that are too difficult to treat?
Once we get the patient in, we're actually pretty good at that. Our physicians, our clinicians are talking with our patients about these things. They know what the recommendations are. They're teaching and encouraging. And we do get those tests. We have partnerships with our local hospital here in Fauquier, with laboratories and with specialists. if we identify somebody who has a potential or a diagnosed cancer, then we take that person and we case manage them and we try and navigate them and help them find their way to the care that they need. If that's through a university system or through the larger network across the state, we'll do whatever it takes to get them in and help them to find their way through that treatment process, which can be really simple or it can be really complicated. And we just take them one at a time.
I guess as the cases become more complex, it must be more and more difficult to find those kinds of services for people who have such economic disadvantages.
Well, the challenge for us is often we are in a fairly rural part of Virginia, and so you may have to travel. And for our patients, frequent travel out of our community to go to that specialist, even if it were free, is super challenging. And so transportation and family arrangements and losing their work or whatever it is often just as immediately challenging as just getting the treatment sorted out. So we do what we can to help people figure out what resources we can find, and our partners and other nonprofits that will help with transportation and the other services. Whatever it takes, we'll do it.
It would be nice if we had a system that put prevention right at the center of things.
It absolutely would. I think we've made some progress. People at least know that this is a problem, but I'm not satisfied. We're not there yet at all.
Well, we thank you for the work you do, and certainly the people you reach. I'm sure they have a great amount of thanks that are owed to you, and I'm sure you hear from them all the time. I'm sure that helps as you continue your hard work. But we appreciate it. Thank you very much for your time as well today, Rob. Rob Marino is with the Fauquier Free Clinic, executive director there, and he's joined us on the John Dingell Cancer Health Disparities and Access interviews. Appreciate your time.
Thanks so much, Miles.
Hello and welcome back to the National Cancer Prevention Workshop, sponsored and produced by lesscancer.org. I'm Miles O'Brien, the chairman of the board of that organization, and we're continuing a series of conversations we're doing this year called the John Dingell Cancer Health Disparities and Access interviews. And we're looking at disparities in healthcare and how that impacts occurrences of cancer and mortality as well. And also broader themes of disparities in health, which brings us to our guest on this segment. Dr. Mona Hanna-Attisha is a pediatrician and professor at Michigan State University. And you may recognize her name as she is the person who blew the lid off of the scandal of Flint's water supply in late 2014 and the lead that was in it, causing untold consequences to this day, really, in that city. And Mona, first of all, thank you for your time.
Miles, it is great to be here with you and to celebrate this important week.
Yeah, this is an important week. And, we're talking about cancer prevention, but we're also just talking about disparities in health. And I think it's worth, I want to talk about what's going on now, but just to refresh people, you, a pediatrician in Flint, Michigan, and you had talking to patients. They were wondering why the water tasted funny, smelled funny. And at first you were like, oh gosh, they would never put bad water in our taps. And then you have a conversation with somebody who says, actually, there's a real problem here. They've switched the supply, there's corrosion, and there's lead in the water. And the minute any healthcare professional hears the word lead in water, that sends up a whole bunch of alarm bells. And you literally marched out in front of a news conference long before there's no time for peer review, and you spilled the beans on this. And just remind people what transpired after that. You went through, there's a very long story, and I encourage you to, by the way, read the book on this, which you penned, called What the Eyes Don't See. It's reads like a Grisham novel, except it's true. What happened after you spilled the beans on that?
Yeah, so I, as a pediatrician, like you said, when I heard lead, I freaked out and I did the research to see what was going on. And not surprisingly, there was a lot of lead in our water and there was more lead in our kids. So spilled the beans, shared that research very publicly at a press conference. And And what happened after that was unexpected for me, because here I am just sharing science, right? And like, can you imagine like being in the middle of a public health crisis and not listening to science? So that was a joke.
I'm shocked that there's gambling in this establishment. Really?
Believe it. I'm just sharing science and I'm just protecting kids. And the science is super clear that there is more letting kids. And that's not what people wanted to hear. And so often when we are trying to protect children, when we're trying to really have policies reflect science, we're often shut down. And there's this kind of huge time lag between making sure we do put into place policies and we do take action that respects science. So my science was attacked, but we persisted, which is, the story of so many scientists and advocates over time. And finally, the state conceded, recognized there was a problem. And since then, I have been really privileged to work on Flint's recovery, trying to eliminate these disparities, trying to limit the impact of this, not only population level lead exposure, but really a population level trauma.
Well, all right. Before we get into that and what's going on now, I just a couple of words on the fact that it wasn't an attack per se on your data. It was really a personal attack, and I do think that during the pandemic, you must have seen some parallels to all this. I'm just curious what your thoughts were as you saw the science being discredited in the context of COVID-19.
Yeah. And I see a silver lining here, and I'm also this eternal optimist. So, the lessons of Flint are the lessons of science denial, of kind of the consequences of disinvesting in public health infrastructure and kind of what keeps people healthy. It's a story about inequities, which we also saw. And these were the same kind of stories that that the pandemic taught us. And there's folks who've read my book recently and they're like, oh my gosh, did you know there was going to be a pandemic when you wrote this book? Like I'm
yeah.
Like, no, I couldn't have predicted there was a pandemic, but these are long-standing issues where as a nation, we tend to be really reactive to crises, and we fail to prevent crises. And it's also, this acknowledgement that not everybody bears the same burden when it comes to these inequities and these crises, especially in the environmental world, also very much in the cancer world. So lots of the same lessons. And for me, that provides me kind of this opportunity of hope. For a long time after Flint, we were encouraging kind of our nation to invest in public health, invest in infrastructure, highlight the role of inequities and disparities. And now that's a global lesson where we all hopefully are recognizing that, hey, we need to spend more money on keeping people healthy rather than on healthcare, which is so much of a sickness-based system. And we need to, invest in infrastructure and invest in our local health departments and also recognize kind of this role of inequities and who bears burdens. So there's a silver lining here, lots of the same lessons that continue to repeat. And I'm hoping that we once again can pause and reflect and learn from history so that we don't keep repeating these same lessons.
Yeah, it's and I know you it's good to maintain your optimism, but it does get tested quite a bit. And when you look at the lack of investment, not just infrastructure but public health, let's talk about public health here, and the lack and what that says is exactly what you were saying, that we don't want to spend money on prevention. And is that human nature or is that something that is unique to the United States? I feel like other countries probably do this a little bit better. And what is it about the American psyche that makes it hard to invest in a little bit of insurance before the house is burning?
Oh, this is a 3-hour conversation. So, why don't we invest in prevention? Right now my efforts are about trying to get the child tax credit expanded in Congress. And, for a minute we had this expanded child tax credit where we proactively investing in the health and development of children. And when you think about this, like this act of prevention is standard in other countries. Like we are a global anomaly when it comes to investing in prevention. And the science is clear. Like, our outcomes are not great. Life expectancy has been dropping the last few years. Infant mortality, disparity, all these other disparities in chronic diseases. We're not doing very good as a nation because we're not investing in public health. Healthcare, as I mentioned before, is very much this sickness-based system. It's reactive. We pour millions and millions of dollars into taking care of people once they're already sick, but we don't invest, once again, in what keeps people healthy. And it's not in that same realm as healthcare. Like, keeping people healthy is things like the child tax credit. It's like raising the minimum wage. It's like universal child care. It's stronger environmental regulations that prevent cancers and so many other disparities. Those are the things that keep people healthy that we don't invest in. I've scratched my head a lot about why are we such a reactive nation when it doesn't really make us any healthier? And I think it kind of really points to special interests that are making a lot of money off of this sickness-based system, not only the healthcare industry, the pharmaceutical industry, but also the industries, be it tobacco or lead or asbestos or coal, these polluting industries that have kind of reaped profits on the backs of people, especially vulnerable people. There's a great book that I would recommend called The Triumph of Doubt by a friend and colleague, David Michaels, who's the former director of OSHA, that really kind of talks about this playbook of industry-driven playbook that has weakened our public health regulations, that has caused us to, have cut funding to public health and regulatory agencies, mainly for the bottom line of these industries. So it's really important for us to ask those why questions to get at kind of these dark money special interests that are making it really hard for us to invest in public health.
Yeah, always follow the money, I guess. And the truth is, we have, on top of all of that, a healthcare system that has profit at its center.
Yes.
So you've got industries trying to make money and getting away with polluting, and then a healthcare industry which, let's call it like it is, isn't unhappy to have sick people because that's the business.
Yes.
So we've really created a mess for ourselves, it seems.
Yeah. I was a quick story. I was at our children's hospital a few years ago, and the rotavirus vaccine had just come out. This prevents diarrheal diseases. Kids used to get admitted with dehydration from rotavirus. And I was at a faculty meeting, and the CEO of the hospital said, we have a big problem. The rotavirus vaccine is working and kids aren't being admitted. And so we're not making money. And I'm like, what are you talking about? Like, this is great news.
I mean, you laugh, but that's just tragic, right?
It is tragic. So we have to kind of shift the incentives of our healthcare industry. And I know this is depressing, but I'm going to come back to hope, because, we can create investments in what keeps people healthy. And I'm going to share a story, because I think it's a kind of a playbook for so many folks who want to create change. So for a long time, for decades, folks have been trying to invest in infrastructure and specifically get lead out of pipes. This is part of our story in Flint. The lead in our pipes poisoned the population, but it's not a unique story. It's an everywhere story. We have a lot of lead in our infrastructure. And this last Congress, the Infrastructure Act included the replacement of lead pipes, billions of dollars, the largest federal investment in lead and water elimination. And that's a success story. I had a chance to testify before Congress a few times about this, and I held up, and I have it with me, I held up a lead pipe, just happened to have a lead pipe here in my office.
Of course.
Of course, like, who doesn't, right? And I shared, and it was a virtual testimony, which is good because you can't bring a lead pipe into Congress, if you remember the game Clue. But I as an optic, which is so important to be good storytellers when we're talking to policymakers, I held up how this pipe, which was one of the first pipes removed in Flint, it looks like a straw, right? And like millions of kids in America were drinking from a straw that was made out of poison that has no safe level, that has terrible impact for millions of children. And that advocacy, along with so many people and for really decades, finally got that investment. It's not enough. We need more, in protecting children. So, this is a long game that we often have to play, to do what needs to be done, to fight special interests, to stay grounded in what's most important, which is people and their health.
So bring us up to date on Flint, and first of all, what's the situation with the water? As I say, that's still a work in progress. And I know you've got a lot of other projects underway there trying to make things better. Tell us a little bit about that as well.
Yeah, so I have all the lead pipes are here with me. Just kidding. So most of the lead pipes have been removed. We're down to like a few hundred. They have to be removed. Our water quality is absolutely better. There's huge trust issues. There's folks in Flint that no matter how good the water is, they'll never touch the water because of that betrayal. And that's really to be understood as part of the trauma of this crisis. So the water is better. My work, I run an initiative called the Pediatric Public Health Initiative, which is advocating for implementing interventions to mitigate the impact of this crisis. We're doing lots of awesome stuff. One of our biggest projects is the Flint Registry, which is funded by CDC, to follow folks who've been exposed to the water crisis, but more importantly, to get them connected to awesome things that evidence tells us promotes the health and development, especially of kids. So connecting folks to things like nutrition programs, education programs, healthcare services, trauma-informed care, medical home access. So lots of great things happening. And the beauty of our work, like I shared with the lead pipe, is that it is not focused on Flint. It is really an everywhere story. It is about making sure that we don't continue to have these same kind of problems. The last time I testified before Congress, I said, Flint's story wasn't the first, it wasn't the worst, and unfortunately, it wasn't the last. These kinds of stories continue to pop up in the news. So we have to make sure in our advocacy and our work that we once again proactively invest in the infrastructure to make sure that kids can just be kids and be healthy, rather than continuously have to kind of defend themselves against crisis after crisis.
It's got to be frustrating to you, though, to see this story repeat itself all over the nation. Why does it keep happening?
So, yeah, shortly after Flint, there was a similar water crisis in New York, New Jersey, and then Benton Harbor, Michigan, another one in Michigan. And then not too long ago in Jackson, Mississippi, and they're still dealing with it. And the storylines are all very similar. They're all stories of environmental racism, where, this impacted disproportionately poor minority communities. It's also stories of kind of dismissal of science and the, lack of government to respond quickly and transparently and protect the most vulnerable among us. So it is frustrating. But once again, there's also glimmers of hope, because in many of these other communities where it's happened again, they've done an even better job than Flint in responding. Newark, New Jersey has already replaced their lead pipes. Benton Harbor, Michigan, in less than a year, has almost fully replaced their lead pipes. In Jackson, Mississippi, we are seeing an unprecedented response from the Department of Justice in terms of civil rights violations and holding folks accountable. So as we continue to lend and listen and support all these other communities, our hope is that they do even better than us, and they have. And I'm hopeful, once again, that with stronger regulations, and more investment and more national awareness, that we will have less and less of these crises, but more importantly, that we'll do better at responding.
Yes, wouldn't that be nice? There is a a component of collective trauma that we all feel about this, but it is particularly felt in communities of color. There are tremendous disparities here. These things don't happen in rich communities. And that's a simple fact. How can we address that? That gets to some very deep issues in our country.
Yeah, Miles, that's a great question. And it's a big part of the Flint story is that environmental health and justice, that what happened in Flint never would have happened in a richer or wider community. And that's not a new story. Throughout our nation, like you said, it continues to be communities of color, poor communities who are disproportionately impacted by environmental injustice. And as we've seen in the pandemic, especially early on, disproportionately impacted by health injustice and other kind of longstanding systemic inequities. Once again, I see hope. Just a few months ago, the Environmental Protection Agency created the Office of Environmental Justice and Civil Rights with a billions of dollar budget. This is huge. This is landmark. This is another kind of big effort to amplify, especially these issues in the environmental space. We also see, progress in health. The CDC recognizes, racism as a public health issue. There's also increasing efforts at ensuring, and recognizing the role of inequities. But a lot more needs to be done. We have to tackle these issues in a systemic way, not continuing to Band-Aid them. Another lesson that we can learn from Flint, part of our recovery is the role of accountability and truth and justice. And I never thought this really pertained to me as a doctor, as a health professional. Like, people would ask me about like lawsuits and criminal charges and civil cases. And I'm like, that's none of my business. Like, I'm just taking care of people. And then I began to kind of really see it as a health issue too. When you have an injustice, it's like a wound. It's like a wound that stays open. And without some sort of restorative justice, that wound never closes and people can't heal, and they live with that trauma, which often gets passed down in generations. This is really important for all of us and for our nation that really has never done a good job dealing with historic injustices that have made people sick. I think that's an important lesson. Like, how do we reckon with bad things that have happened to people in history, so that there aren't these ongoing disparities and inequities?
What about the mental health issues that come out of this, the trauma, the depression, the PTSD, all these things you're talking about have long-lasting consequences, which are completely separate from whatever the lead might do to a young child.
Spot on. And we're seeing that in the registry. We're seeing that in other studies. We're seeing kind of the effects of PTSD, the mental health issues, and then layer the pandemic on top of that, especially for younger folks, and anxiety and depression, and also the kind of the sense of betrayal that folks out there were supposed to keep them healthy and safe and failed. And there's this kind of severing of the social contract. So yes, we see the mental health issues acutely, which is why we've also tried to be proactive in terms of really embracing trauma-informed care and trauma-informed services, 24-hour crisis lines, destigmatizing mental health, which is really important, and providing some of this kind of proactive resources. Something else that I love to share that Flint is doing is Flint's really embraced mindfulness. We're one of the first 4 mindful cities in the country. Even our mayor has gotten like mindfulness training, and all our business leaders and our healthcare and teachers, and it started in our elementary schools as kind of this another tool to address some of the mental health issues. Not enough. We need a lot more resources to be able to care for folks.
Sounds a little bit like Flintlandia, little different, a different kind of Flint. Good. I'm glad this is good. So, Mona, I got to ask you, you were a pediatrician, just kind of minding your own business, doing your job. And you really did, by virtue of discovering this and bringing it to light, put yourself on a national stage. And do you feel compelled to keep talking about these issues and marching them forward? And what do you see as some of the other challenges that you'd like to tackle?
Oh, thank you for that question. So, yes, I feel like I have been given this amazing microphone, and I'm going to hold on to it as long as I can, advocating for as many kids and communities as I can. And this is what I was trained to do. I'm still a pediatrician, still seeing kiddos in clinic. I was rounding on the floors recently with all the RSV and flu patients. So still grounded kind of in kids and taking care of them. But also recognizing that, so much of what makes children and people sick is things that we can't prescribe away. and that really we have to address these upstream determinants of health if we truly want to make people healthy. Addressing things like air quality and water quality, and and childhood poverty, and racism and unemployment, and income inequality. There's these big things that make it really hard for a kid that I see in clinic to be healthy and successful. So I am blessed and privileged to continue to be able to advocate for many of these issues. The challenge that I'm working on right now is the issue of child poverty, which infects so many of our children. It is embarrassing. In Flint, our child poverty rate is over 50%. In some neighborhoods, it's 80 to 100%. And that's not okay. And that's also not unique to our community. That's throughout this nation, and it's also very anomalous. So trying to really get at these upstream issues so that we don't keep band-aiding. We don't keep, we're doing great things in Flint that I shared, but a lot of this are kind of Band-Aids because we aren't addressing these bigger issues that make it, once again, really hard for people to be healthy and successful.
We're too wealthy a nation to allow this to exist, aren't we?
The most powerful, the richest nation in the world, yet we have millions of children who grow up with no chance of achieving that American promise.
All right. I didn't want to leave it on a down note, but I will say this.
Stop, and we can all be part of these movements to create change. And I once again, I see hope. I see windows of opportunity. And I think more people who care about this stuff, the more good that we will do.
Well, I knew you'd save me there. And I will say this, whatever you do, don't let go of that microphone. You are a national treasure, and you need to keep talking and crusading and fighting this good fight. And I want to thank you for all your service. Dr. Mona Hanna-Attisha, who you may know from Flint, but you're going to keep hearing from her as time goes on, as she continues these important fights about disparities in health. Thank you, Mona, for your time.
Thank you, Miles. It's a privilege to talk to you.
Welcome back to the National Cancer Prevention Workshop produced by Less Cancer. My name is Miles O'Brien. I am the chairman of the board of that worthy charity. And we have been talking with people about disparities and health outcomes. But we want to pause and take a moment to acknowledge someone who's been integral to getting the message of Less Cancer, not just out to the general public, but to healthcare professionals. Dr. Jan Balmer is the Director of Continuing Medical Education at the University of Virginia School of Medicine. She's been in the CME business, as it is called, for about 30 years. She obviously started as a baby. Jan, first of all, welcome.
Thank you so much. I'm very happy to be here. This is going to be a fun conversation. I'm looking forward to it.
Yeah. Now, I assume a lot of people who are listening to us right now know exactly what CME is, but let's assume people don't fully appreciate what continuing medical education is and how important it is. As I understand it, it's been around for about 100 years or so, give or take. You've done a good chunk of that period of time, 30 years of coverage over this field, and I'm sure you've seen a lot of changes. First of all, CME, why do we have this in the first place?
So all of the health professions, medicine, nursing, pharmacy, social work, all of these, dentistry, all require that healthcare professionals maintain their knowledge and are updated regularly to provide quality care, and to be aware of all of the latest advances in science and all of those kinds of things. And it affects their ability. The only way they can practice is to have a license. And so most of the states require some kind of continuing education for licensure. And then on top of that, many of the professions also have what they call board certification, which is sort of an accelerated or an advanced or higher level of learning and documentation of expertise. And so both of those factors are really important in terms of making sure that our healthcare professionals and our healthcare teams are well-versed and knowledgeable about all of the advances in science that are happening. And they need to be able to have access to that information. And so the field of continuing medical education and continuing education for the health professions really focuses on making sure that what we provide are evidence-based, scientifically oriented, and patient care focused continuing education opportunities, either through case studies or lectures or panel discussions or actual simulations and demonstrations, all kinds of hands-on workshops, so that people are really practicing and building their expertise. That's why medical practice is called practice, is because you continue to get better at it over time. Nursing practice is the same. So our role in continuing medical education and continuing education is to make sure that those opportunities are available and that we're really supporting our healthcare professionals and our healthcare teams in meeting all of the needs of their patients and promoting optimum health outcomes for everybody.
So it's a lot of work to find the good stuff. And I know you have to do a lot of vetting to ensure there's no conflicts of interest, et cetera. How do you go about your work in finding good material to share with medical professionals?
So what we really do is talk to our clinicians and look at what the latest research is, and then find out sort of where the gaps in knowledge are. What would be the ideal level of care, and sort of where are the glitches in the system that are preventing that from happening, either because someone doesn't have the right knowledge, or they don't have access to the right information, or the system itself doesn't really foster or provide the support that the healthcare professionals and teams need. And then what we do is design education to address those things, to try to come up with strategies and approaches that help to foster better discussion, new ideas, other kinds of things, make system changes so that our healthcare teams can actually do the work that they need to do, that is promoting optimum care.
Now, over the years, though, I know there have been problems with, say, pharmaceutical industry supporting this kind of thing and perhaps putting their thumb on the scale a little bit. How do you guard against that?
So the way we do it is that there have been a lot of, this is probably one of the biggest changes in the 30 years that I've been here, but it actually started before I started in this field. But the bottom line is that industry has a very specific focus, and their specific focus is to make sure, and it's required by the FDA, to make sure that healthcare professionals know what the drugs do and how to deliver the drugs appropriately and all of those kinds of things. Those are considered in our field promotional education because they're related to sales of products. Accredited continuing medical education is very different. If we're going to talk about any products, we're going to talk about all the products in a particular field and what the strengths and weaknesses of each of them are, or how they work differently, so that physicians can make informed decisions. And we put it in the context of patient care so that they can figure out how to stratify and make informed decisions in a way that optimizes it for each individual patient that they care for. So we really have to rely on the latest research, what the current standards of care are. Many of the national specialty societies come up with clinical guidelines and other kinds of things. We use those as benchmarks as well, to make sure that we're doing the kinds of things that need to be done that are solely evidence-based and don't have any promotional bias. They don't promote one product over another. They just talk about how they all work differently. And a lot of the work that we do really is not product specific. It really is patient care focused. And so it's a different pathway, I guess, is the best way to explain it. We will talk about products when it's appropriate, but there's a lot of things that we talk about that maybe aren't have any relationship to products.
I imagine, medicine is so specialized and complex these days. It must be really challenging to know, because you're dealing with an audience that is extremely sophisticated and needs to get the latest information. How do you, because no one person can know everything, right? How do you get the knowledge base in order to find material that is relevant and cutting edge, so to speak?
So we work in collaboration with our clinicians and our faculty here. It really is a collaborative process. What continuing medical education professionals bring to the table and continuing education professionals bring to the table is our expertise in educational design, our knowledge about accreditation, all of the design and strategic developments, and making sure that it's not promotional, that it really is fair and balanced and meets those kinds of needs. And then we work with our faculty who are our content experts, who know all of the latest advances and know all of the really important things that are going on, so that we can do it as a collaborative process. I have a really interesting example where we've been working on adverse events associated with immunotherapy and cancer. So there are different side effects associated with immunotherapy because the way the drugs work are different than with chemotherapy. So chemotherapy basically goes in and tries to kill all the cancer cells, but it also negatively affects the immune system of the patient. Immunotherapy utilizes the immune system to negate or minimize or destroy the cancer cells. So they're very different processes. And so the side effects are different. Well, what we have found is that when patients have those kinds of side effects, where they end up going up to close to 40% of the time are to the emergency room, their primary care physician, their primary care provider, remote hospitals, because they may be traveling a long distance to get to cancer. And so they may not be talking to the oncologist who is very knowledgeable about immunotherapy. They may be talking to healthcare teams who don't know hardly anything about immunotherapy, who have much less knowledge about it. So that's a good example of a gap. So what we're doing now is creating educational activities and resources and tools and other kinds of things for emergency medicine and primary care physicians and providers, so that they can be informed in a way that can get them working and collaborating with the oncology team to make sure that we're doing the right things that are in the best interest of the patients. So that's the kind of work we do, and that's why it's so much fun.
It sounds fun, but it sounds very labor intensive too. You must have a pretty big staff to pull this all off.
I have a wonderful staff of 11 people, and we run about 250 activities a year. We work with 20 hospitals across the state, as well as national societies and organizations, as well as all of our faculty and staff here at the University of Virginia. So we stay very busy, but it's good work. You can feel like you're making a difference, and you're supporting the integrity of the healthcare teams that are providing good care, and you're supporting your faculty as well as supporting your patients. It really is, and you have an opportunity to really make an impact, which I think is just really marvelous.
So over 3-decade career, what are some of the big trends you've observed in CME?
So I think the big trends is that industry used to support lots and lots and lots of continuing education. Because of all of the changes in the rules, the Physicians Payment Sunshine Act, there's FDA guidances and other kinds of things. Pharma has their own guidance as well. What we found is that industry is much more selective. It's also why you saw the direct-to-consumer movement move forward, was because there were so many restrictions on interactions between physicians and industry that were creating potentially a conflict of interest. I think that's probably the biggest thing. I think also as technology has improved, we're doing more and more technology just-in-time kinds of activities. It used to be that everyone went to national meetings and maybe would go for a whole week. Now people are really doing a lot of things remotely through Zoom, like we're doing today, really looking at ways that they could get access to information just in time in a very quick turnaround so that they can be thoughtful about what they're doing and informed on any given day. We do know that physicians have about 30 questions a day that they have to seek an answer for. And so our goal is to make sure that those resources are available and that it's coming from us as a trusted resource. So those are the kinds of things that I think are changing a lot. COVID also changed things pretty substantially. Our grand rounds are, most people don't know this, but every healthcare system and almost every hospital has some ongoing educational activity in their hospital. We have 50 of them that go on here at UVA weekly in every specialty. And so, but they're usually about an hour long. And they were always in person. So they would always meet in an auditorium. But now they can meet by Zoom or by WebEx or any other, Teams or whatever the tool is, technology tool is. But the really nice part is it's actually increased participation because they don't have to try to get to a meeting space. Because if they get caught up doing something else, they can actually get on and participate in a way that they weren't able to do so before. They can also do it on their phones. They can do it in their cars. So, the technology has changed, but it also changes how we design things, what the length of them are. Used to be everything was at least a minimum of an hour. We're now providing content in 5 and 10 minute segments. We're giving credit in 15-minute segments. It's changed the whole form and fabric in a way that is, I think, very positive. Because we're really meeting people where they are, our clinicians where they are, and our teams where they are, as opposed to expecting them to come to us. So I think all of those things are really important. The accreditation rules continue to change, which is also a really fun thing. As the environment and the society around us change, and society had a big deal. I mean, it was really important to society that there not be a conflict of interest and that they weren't getting treatments based on who the best salesperson was from industry. So, or who the best company was in terms of promoting their products. And so all of the work that we have done in terms of making sure that the integrity of those educational programs is top quality is really important and valuable across the system. And society expects that and needs that from us. And we're really happy to provide it. But it really is a collaborative, work-intensive, really interesting process, because the timeframes can be really short. We can do something in 3 to 6 months if we need to, or even shorter if we absolutely have to. But it keeps us busy.
Yeah. How soon before you're on TikTok, right?
Yeah, I don't know. We may end up on TikTok. I don't know. Well, there's a lot of stuff that's happening on Twitter already. One of our Tyson Bell is one of our infectious disease pulmonary specialists who has been all over the national news media around COVID. And he's got a huge number of Twitter followers, and people hang on every word he says in terms of what they do. So I think, it's really interesting to see how all of those things shift and change. And so that's what's made it fun.
So, obviously technology is a great enabler, as you've just been talking about, but I wonder, do you get the sense, do you have any metrics of understanding whether this is more or less effective a tool for actually learning? Do people learn as well with all of these additional electronic tools we've been talking about?
Yeah, I think they do. Adult learners are very different than undergraduate medical or college students or other kinds of things, because all of adult learners all have work to do. Learning has to be woven into their daily routines and into their activities. And what we found is the demands of delivering healthcare continue to increase. And so not taking a whole hour is sometimes more than they can afford. But putting it in small, very focused packets, we pack what we call packetizing it and breaking it down into small modules and other kinds of things, make it much more easy to process. The other thing is that we know that sequential learning for adult learners is particularly important. And so if they listen to something and it's 15 minutes, but then they come back a week later and need to be reinforced, the technology, they can come back and do that. Whereas if you were at a live meeting, you know, by the end of a full day of a live meeting, you're sort of in brain overload and you can't always remember it. And we used to make these huge paper syllabi that had all of the materials in it and everything. And what we found was people couldn't fit the syllabus in their suitcases, and so they would leave them in the hotel rooms. So that wasn't really helpful.
This kind of defeats the purpose. I guess.
Right. It defeats the purpose. So we moved to an electronic syllabus so that you can go back and look at something if you want to. We also make it available, you know, videos available and other kinds of things. So I think it does help. I think where it doesn't help is the conversation and the team building and the sort of you know, day-to-day learning that you need to have and the collaboration. Those communication-based things require that you be in a room together. And so you have to figure out how to balance those two things. You know, all of us are used to texting on the phone, but we all know that texting is very different than it's sort of 1 degree of separation away from having a real conversation with somebody. So there are places and times and situations that really warrant a real conversation and a real collaborative discussion. And those kinds of situations, applied learning situations, are situations that really require in person. And so we have to figure out ways to balance and make both of those available. We're always going to have both. I think both will always be part of the world that we live in, because they have to be there. We just need the collaboration in order to make it work.
Let's talk a little bit about the National Cancer Prevention Workshop. And full disclosure, you're a member of the board of Less Cancer, former chairperson. So you have some attachment to the organization. Help me understand the message that comes out of Less Cancer and this workshop, which is about prevention. Is that kind of new in the CME world to talk that way? Because clearly, you know, medicine is about treating people, not necessarily preventing things.
Right, but the healthcare system is also changing, and it's now going to value-based care. So you're not fee for service anymore. So when you're fee for service, it doesn't matter as much, right? Because you're going to get paid regardless. Value-based care is a little different. You're not going to get the same kind of reimbursements and the same kinds of things. So now there's a real advantage to preventive care. So there's a much more incentive, as it were, financial as well as systems-based incentive to promote preventive kinds of strategies, having those discussions, encouraging people to think about it. And in the cancer field, that's particularly important. Cancer is devastating to families and devastating to the patient and very difficult to navigate that space. And so if we can prevent and have people do the kinds of preventive behaviors, eating better, exercising, doing the screening exams that they need to do. You know, Dr. Townsend talked to you about HPV and the benefits of a vaccine that can actually prevent cancer. Those kinds of things are incredibly important. Plus the fact we need to really hold industry, not commercial industry, pharmaceutical industry, but big industry accountable. You know, Rob Balat sits on our board as well. You know, industry needs to be accountable for helping minimize the carcinogens that are in the environment around us. And if they aren't willing to do that, then we need to be able to have incentives or disincentives that affect their business model in a way that makes them more likely to improve the quality of the work that they're doing as well, just like you would expect the quality of a healthcare professional and a healthcare team to give you optimum care. We should expect nothing less from the other industries that potentially are putting carcinogens in the environment. And many of us didn't know anything about it, you know. I mean, it's Christmas time, you know, it's Christmas time, right? You know, the holiday season is around, and you know, everybody used to smoke. I mean, in World War II, they sent cigarettes in the packets for soldiers. You know, clearly no one would do that now. We've learned much more about the science. The science changes all the time, which is why the field of continuing education is so critically important, is because it doesn't stay the same. And things that clinicians learned 20 and 30 years ago may not be the right approach any longer. And so we have to keep everybody current. You know, and industry needs to be held to, all industries need to be held accountable to making sure that prevention is front and center, major part of whatever the business model is that they employ. You know,
So-
healthcare insurance is paid by businesses. Most of it's employer paid. So there's a real benefit to them to do it right the first time, but that has, you know, that's still in transformation. I think it's still, we're having better conversations about it. And thank goodness Bill Cousins holds all our feet to fire and keeps us moving and having those conversations, because it has to happen at multiple levels. And the thing I love about cancer prevention and the National Cancer Prevention Workshop, the best is that it's not limited to only one segment of the population, that we talk to policymakers and we talk to the general public and we talk to healthcare teams and we talk to communities and we talk to churches and volunteers. I mean, we're really trying to engage all of the communities that can help us have a voice in terms of promoting prevention. And while continuing medical education is a part of it, it's not the only part of it. So, I mean, that's why I like it so much.
Do you get pretty good feedback from the CME community for the content which Less Cancer, Bill Cousins, and the Cancer Prevention Workshop provides?
Yes. And we're sharing that information more and more all the time. And we actually reproduced some of them, you know, did some post-production on some of the things and put them on things like Coursera, which has 1 million users. You know, we also have it sitting on our website and our platform, and I share it with we share it with all of our other hospitals, and we talk about it at national meetings, because it's a different kind of a model. Plus, Bill's always sending it out on social media. So I think, you know, the interesting part is that there's not a single pathway anymore for distribution. The more distribution pathways you can create, the better off you are. And maybe we should look at TikTok, because we haven't done that yet.
Why not?
Yeah, but I think those things are important. You know, I think they're incredibly important.
If I know Bill, he's probably already exploring that. So just a thought, a personal word or two. You've had a really long and stellar and excellent career, and I know you love what you do. Are you looking forward to the next chapter, or are you going to be sad to leave it?
I think there's always going to be some mixed emotions. I have such a great team here. I believe that that they will carry on well. It is going to feel very odd not to be here all the time, but I already know that there are some projects that I'm going to continue with, and at some level and in some capacity. I'm looking for a different balance, you know, for my personal life. I'm fortunate to have a 95-year-old mother who is healthy, that I would like to spend a little more time with. You know, so I think it's about sort of recalibrating a little bit. And so I am looking forward to doing some traveling, visiting some friends, but I fully expect to still be in this space and doing some interesting projects and helping out where I can, because I can't imagine not helping where I can.
Well, do us a favor. Don't retire from the Less Cancer Board anytime soon. We really need your input, and we really appreciate your expertise. It's really important to have people like you a part of this prevention message.
Well, thank you. I love it. I really love it. I mean, you know what? It's just so much fun, and it's a great group. So absolutely, I will be on the board for a while.
Okay, good. So we're not going to say goodbye, but congratulations on your retirement. And thank you for shedding so much light on CMEs. It's really actually it's a fascinating subject, and it's not the kind of thing I think we think about when we go see our clinicians, but it's so important that they're up to speed. And boy, 30 questions a day, that's a lot of information that they need, and it's good you're helping provide it. So Jan Balmer, thank you so much to you and your staff, and keep up the good work. Even after you're gone, I'm sure it will continue.
Well, thank you so much. I really appreciate the opportunity to share with you today.
Hi, everybody. My name's Bill Cousins. I'm the founder of Less Cancer, officially known as Next Generation Choices Foundation. So we're going into our 20th year, and this is our 10th workshop. None of this could have happened without any of you, your support, participation, our donors, our board. We're so grateful to each of you. This year, we have a special focus on health disparities, health access relative to cancer. It's an issue I'm very passionate about, close to. I can't thank you enough for supporting us, being part of this, and making this happen. Thanks for everything, everybody.
Good afternoon. I'm Debbie Dingell, Congresswoman from Michigan's 6th Congressional District. I'm very glad to be with you all this afternoon as you begin this year's Cancer Prevention Workshop. For the past several years, I have worked with Less Cancer to increase education and awareness about cancer prevention. In fact, we established the Bipartisan Congressional Cancer Prevention Caucus in 2015 together to give policymakers a forum to discuss our efforts to reduce preventable cancer. This year, I am very happy and glad and thankful to welcome Congressman John James as my new co-chair. I look forward to our partnership and the work we will be able to accomplish across the country, not just in Michigan, together. As co-chairs of the Cancer Prevention Caucus, we will soon be introducing a resolution to honor February 4th as the National Cancer Prevention Day, to make sure that we are spotlighting the devastating effect cancer has on our communities and things that all of us can be doing every single day to help prevent it. But we know prevention and early detection are only made possible when every American has access to preventative healthcare services and annual routine screenings. I've been a co-sponsor of the Medicare Multi-Cancer Early Detection Screening Coverage Act, which would require Medicare to provide coverage for multi-cancer early detection screening tests. And I also introduced the Access to Breast Cancer Diagnostics Act to require insurance companies to cover breast cancer diagnostic testing the same way screenings are covered. Still, more must be done to increase healthcare and access to healthcare and reduce the prevalence of cancer in too many of our communities. There continues to be wide racial, socioeconomic, and geographic disparities in cancer outcomes, screening, and treatment. For example, those who lack health insurance grow up in polluted communities or lack reliable access to healthcare are at higher risk to being diagnosed with cancer and experiencing poor health outcomes. And it's unacceptable. That's why we come together every year to work to achieve health equity in communities across America. And it's a good time to remind each other and also for me to work with my colleagues, that advocacy and education is a good reminder that each of us can take responsibility for things each day in doing checks. From making sure we're looking for new spots that could potentially be skin cancer, making sure that we are examining our breasts for lumps, other things that happen in our body, and then that we call a doctor. But when we do find things, every person should be able to get access to a doctor to follow up and to have the tests they need. Thank all of you for your commitment to amplifying this important mission, and I look forward to continuing to partner with you to prevent and reduce cancer. It's an honor to be a part of this mission with you.
I'm a business owner. In business, you have to take care of your people. That's why my employees were on the exact same healthcare plan as my family. And when COVID-19 hit, I made sure everyone could keep their health care in a healthcare crisis. But it's not just about taking care of people in a crisis. In the Army, I also learned that preparedness counts. It's the difference between life and death. You don't go into battle unprepared, and when it comes to fighting cancer, it's no different. It starts with eating the right foods, which means protecting our vital farmland from overdevelopment and foreign speculators, and making sure that family farms that make up 95% of the agriculture in my home state of Michigan can keep passing down their operations from generation to generation. Cancer has touched nearly every family fighting this disease, and we need to start arming America with knowledge, resources, and the help they need. That's why I'm here. That's why I'm here to support those who work each and every single day to fight cancer. Across America, cancer is the reason for almost 1 out of every 4 deaths. It's the second highest cause of death for kids aged 1 to 14 years old nationwide. And this year, the American Cancer Society estimates there will be almost 2 million new cancer cases and over 600,000 cancer deaths in the United States alone. But here's the good news, the bright silver lining in this dark, dark cloud of cancer. More than 50% of cancers are preventable, but only if Americans are armed and equipped with the awareness and resources that they need. They say the best offense is a strong defense. It's true with cancer as well. And it's true with national security. And there's no bigger thing to making sure we have a secure nation, to make sure we have a healthy America. With access to preventative medicine, we can make cancer deaths virtually zero. With a strong, healthy nation from birth on through life, we are building a strong country. The key to a strong national defense, as I said, is a healthy people. We can be even stronger by thinking outside the box and making sure that America remains the hub for medical innovation so the technologies to end cancer are right here at home. That's why I'm passionate about the work the Congressional Cancer Prevention Caucus is doing. I'm also grateful to this nation's world-class scientists, doctors, nurses, and medical support professionals who take care of all of us at our times of need and before. I'm proud to support you in this fight against cancer and serving those most in need. Let's kick cancer.
Good morning. I'm Donna Eco, board member of Next Generation Choices Foundation, more commonly known as Less Cancer. And it's my privilege and pleasure to again interview Don Beyer, congressman from Virginia, and a great advocate for healthcare for not only his own constituents, but also for the Americans all over. It's great to see you. Thank you for helping us at the National Cancer Prevention Workshop. This year, we are really focusing on cancer and health disparities. And I know that these can be in the context of race, ethnicity, age, sexual identity, education, so many types of disparities. And we wanted to know about things you might be working on that can help address some of the unequal accesses to healthcare.
Great. Well, Donna, thanks so much for inviting me back again. I love our conversations, and I'm so grateful to you for your years and years of leadership on Less Cancer. You're making a big difference. Just quick overview, 33% drop in cancer mortality since 1991. And if you do the math, that's almost 4 million deaths prevented, largely driven by progress against the four most common cancer types: lung, colorectal, breast, and prostate. which is really, really exciting. I have a friend who is a colorectal surgeon, and he said he's not operating on a lot of older people anymore because so many people are getting the colonoscopies, even if it's only 60%, that he's seeing less and less of it. But I was amazed just this last week that they reported a 65% reduction in cervical cancer rates among young women, 20 to 24, in the years from 2012 to 2019. That was the HPV vaccine. I know it was a little controversial at first. I remember when Tim Kaine was our governor and really tried to mandate it for every teenage girl and increasingly teenage boys. We got our girls done at 13. And oh my God, what a huge difference it makes. I'm a little concerned because the importance of tackling cancers through not just behavioral changes, but vaccination to prevent infection is proven to be really, really important. But at the same time, we're getting this vaccine pushback as a result of COVID and people not vaccinating their kids for measles, for example, and pulling back. So I'm hoping that the current anti-vaccine misinformation hysteria is short-lived, because we have such an opportunity to make a difference on cancer with vaccinations, and we need to push forward. And that's especially true because the EBV and RSV vaccines are supposed to be coming very soon. But to pivot, Donna, to your concern about disparity, let me go close to home for prostate cancer. It's the second leading cause of cancer death for men, and it increased 3% per year, which is not a lot, but 3% per year means that it doubles in 24 years. From 2014 to 2019, it had been going down for 2 whole decades, and now it's on its way back up. And it's specifically growing in its most serious, advanced disease. But to the disparity, Black men are 70% more likely to get prostate cancer than white men. Their cancer mortality rate is 2 to 4 times greater than white men, than any other racial or ethnic group. So we clearly, right there, smacking us in the face, is this issue of disparity among Black men and prostate cancer. I introduced a bill with, and not just me, but I was the lead on it, the Addressing COVID-19 Health Disparities Act, which is specifically about the disparate impact on COVID response. We saw some communities were being hit harder, and we could improve our healthcare delivery. And we always know that social determinants of health are a contributing factor. Poor nutrition, poor education, poor access to healthcare, and that in general, people of color are less likely to receive high quality healthcare, even than white people, even when health insurance status, age, severity, disease, health, all that are comparable. Ayanna Pressley, who's a member of Congress from Boston, she and I led a letter to the CDC to collect the demographic data on long COVID, just to look and see what are the disparities there in terms of the, New York Times says 7 to 21 million people affected by long COVID. I think CDC says 2 to 3 million are not working, just are out of the labor force because of long COVID. And understanding these disparities will help a lot more. But one more thing, I introduced the Improving Diagnosis in Medicine Act late last year. I did it with Kim Schreier, who's a pediatrician from Washington State, because it's one of the things we're discovering is that diagnostic errors, just figuring out the wrong disease, 12 million Americans annually, and about 10% of patient deaths where we're just treating the wrong thing. And from a cost standpoint, we're always trying to bring down the cost of Medicare, Medicaid, our health insurance. Just misdiagnosis is $100 billion annually. So wow. There are a lot of different reasons for it, breakdowns in communication and coordinating care, reading the wrong chart. I love it when I go in for something and they try again and again to make sure this is the left leg and this is the right leg, writing which hand's going to be operated on and which hand's not going to be operated on. But test results can get lost, and especially in a lot of underserved areas, the subspecialty consultation that you need may not be available, or you don't have the test equipment, or it's malfunctioning. So this whole idea of Improving Diagnostics in Medicine Act creates a new grant program for establishing these research centers of diagnostic excellence. You know, I'm the only certified auto mechanic in Congress, I think. And Donna, so much of fixing a car is trying to get the right diagnostic process at every time. And human bodies are so much more complicated by factors of hundreds of thousands than a simple car. So I really look forward to reintroducing the bill. I'll stop, I'll pause, but let me just say that if you think that disparity is a big issue with COVID, just think what it is with all these different kind of cancers that are out there.
Exactly. Well, Don, you have made all my points and answered most of my questions, which is wonderful. Maybe you could give me just a general overview of kind of where you're, you know, we have a new Congress. Obviously, we've all been riveted watching all the drama around that, but everybody is seated now. And I just wondered if you think there is an appetite in the new Congress for looking at some of these health issues. I mean, it seems to me that this would be one area where you could get some bipartisan consensus. I mean, everybody's constituents have these same problems. And I'm wondering if you see that as an area where you might be able to work with the other side and there might be some middle ground and some hope that we can on these attacks.
I should hope so, because the other side, you know, they get cancer too, and it affects their families. In fact, one of the I think one of the missing Republicans during the Kevin McCarthy vote series had to go home because one of the family members had a cancer diagnosis. You know, and happily they're able to get back to, happily for them, they're able to get back and vote.
Yeah.
I'm cautiously optimistic. Well, I'm really optimistic when you think that we passed the Chips and Science Act last year, and most people focused on the, you know, the $50 billion for new semiconductor chip manufacture around the country. But the missing part is we basically doubled the National Science Foundation budget and also a huge increase to the NIH budget. You know, that we know that our ability to solve all these diseases comes about because we're investing in basic science. And so that's going to be paying dividends for years to come. And that wasn't really bipartisan in the House, but it was very bipartisan in the Senate. But we did pick up some Republican votes. The greater, and the things like, you know, in the Inflation Reduction Act, we capped Medicare insulin at $35, which was wonderful. The bad news is there are people that aren't on Medicare that it may still pay $800 a month for insulin, but we've moved in the right direction in a big way. And hopefully when that becomes accepted as the standard $35 a month limit for insulin, yeah, we got almost 70 million Americans that are pre-diabetic right now. You know, 25% of Medicare costs are just end-stage renal disease, you know, dialysis for basically diabetes patients. It's an enormous sadness and tragedy, but also opportunity for us to move forward. But the real challenge, Donna, no surprise, is that through the pandemic and the latter part of the Trump administration, our budget deficit, public debt, total national debt surged from like 19 trillion to 31 trillion. And we're all, no one really knows how much debt we can run up without having it affect us in a really negative way. But we all think, there's an old Herb Stein line, who used to be chair of the Council of Economic Advisors, that if something's too good to be true, it's not true. And so my Republican colleagues are understandably going to try to figure out, how do you rein in overall costs? How do you reduce the cost curve? And while they're trying to do that, it's difficult to expand other benefits. Now, the weird part is that the more effective our healthcare is, the less we end up spending on Medicare and Medicaid. Imagine if we didn't have all that type 2 diabetes. That would be an enormous impact. In fact, there's a lot of really interesting studies that when you move Medicare eligibility down from 65, it actually saves you money, because then they're less sick when they get to be 65. And the costs start to get great. You know, the earlier you start to provide care, the more likely they are to be healthier longer.
Yeah, well, and that very much goes to what we're talking about today, the importance of solving some of the health disparities. in order to have, not only less cancer, but general health improvement overall. I want to thank you so much for your leadership in so many areas, but particularly in looking at science and looking at medical issues and helping us reduce the incidence of cancer and health disparities. And so grateful for all you've done and your leadership, and especially your support of less cancer, especially today on National Cancer Prevention Workshop. Thank you.
Thank you, Don, and thank you for your leadership. I'm so pleased that you're changing the way the world works for those of us, all of us, who face the risk of cancer.
Hello, I'm Madeline Dean, Congresswoman for Pennsylvania's 4th Congressional District, Montgomery and Berks counties. I am honored to once again join Less Cancer to mark National Cancer Prevention Day. Whether it's a loved one or even yourself, we all hold stories of those close to our hearts and how prevention saved lives. For me, I think of my beautiful mother, Mary Eaton Dean. When she was a young woman, she had melanoma, but it was caught early and prevention took care of that and saved her life. Sadly, unfortunately, when she was 70, we found out that she had ovarian cancer at a very, very late stage, and she lost her life to ovarian cancer very, very quickly. I also have 3 brothers who have had either melanoma, skin cancer, or other cancers found early and lives saved. So our family, like so many others, I don't know many that haven't been touched by cancer, know the importance of early detection and treatments, and we've come a long way. There are so many stories of hope. We have to strive for those as we struggle through the grief of those we've lost. This is a day about spreading awareness and education about how we can reduce our risk of cancer by prioritizing our health and our environment. Less Cancer's theme for this year focuses on cancer and disparities. I'm so glad for that focus. We can do more. We must do more to educate and legislate so that people in every community, anywhere in our nation, have the knowledge and the access to protect themselves and their loved ones from these devastating diseases. I'm proud that President Biden and his administration share this goal as well. Thank you to Less Cancer and your board and your committed members, and to all of those working to literally save lives.
Hey everybody, Brian Fitzpatrick from Pennsylvania's 1st Congressional District, and I'm honored to talk to you all about the importance of cancer prevention efforts by the medical and public health communities. Cancer is the 2nd leading cause of death in the United States, and the COVID-19 pandemic has only exacerbated the number of Americans who lose their lives to cancer. As is true for so many Americans, the fight against cancer is personal to me. The most important tool for combating cancer is supporting prevention. Efforts to bolster the ability to prevent and detect cancer early on have significantly increased the number of patients who are able to defeat cancer. Certain groups continue to be at increased risk of developing or dying from specific types of cancer. To state a few, according to the NCI, African Americans have higher death rates than all other racial or ethnic groups for many types of cancer. Moreover, Hispanic as well as African American women tend to have higher rates of cervical cancer than women of other racial or ethnic groups. That is why I have led efforts to strengthen diversity in clinical trials, as well as promote more research toward women's lung cancer research. As the co-chair of the House Cancer Caucus, I will continue to fight for legislation that boosts funding for cancer research, supports patients, survivors, and families, and bolster prevention efforts across the board to ensure that cancer disparities are eliminated. And I'm proud to partner with organizations like Less Cancer to work towards stopping preventable cancers at the root and empowering Americans to prioritize early testing. Thank you all for your commitment to the fight against cancer, and I look forward to continuing to work with you to end cancer forever. God bless.
Hi, everyone. I'm Ro Khanna. I represent Silicon Valley in the United States Congress. Thank you for inviting me to speak to Less Cancer's National Cancer Center Prevention event. And thank you to the board for the extraordinary work you do, to all of you for your work in fighting cancer. I know this conference is focused particularly on racial and economic disparities, and that is a huge issue. African Americans who have cancer have much worse outcomes than those of other races. And the same is true of those who are economically poor, those who don't have health insurance. We need to make sure that every American, regardless of race, regardless of economic status, has equal treatment when it comes to cancer, has equal treatment when it comes to preventing cancer. That work that you're doing is so important, and it's consistent with President Biden's moonshot goal for us to really tackle cancer, to develop cures, to develop prevention, and to help make sure that every American is treated with equity. Thank you for your work. Thank you for this conference, and I wish you really well in this noble endeavor.
Hi, everyone. I'm Congressman Chris Pappas from New Hampshire. I'm really pleased to join Less Cancer to discuss the importance of education and advocacy and the weight that that holds in reducing the risk of cancer. I want to thank Less Cancer's board of directors for their dedication to this cause and their organizers like my friend Mandi for making this event possible. Less Cancer uses 3 approaches to address cancer prevention: reach out to the public, advocate for change, and participate in public discussion. National Cancer Prevention Day combines all of these approaches to raise awareness and reduce cancer risk in our community. And I want to thank all of you for joining today to continue our work toward that goal. New Hampshire is not untouched by cancer. In fact, we have some of the highest rates in the country. We experience high rates of pediatric, bladder, breast, and thyroid cancers. And we have significant concerns about environmental issues, including PFAS contamination in water that communities are drinking and are harmful to human health. And we know that those are linked to chronic diseases, including cancer. As a member of Congress, I've led a range of efforts to secure clean drinking water, reduce the incidence of cancer, and increase prevention. I've led efforts to hold PFAS polluters accountable and ensure that our communities have safe, clean drinking water. And I was proud in the last Congress that we passed the Honoring Our Pact Act, which expands healthcare for veterans who've been exposed to toxic substances through their service to our nation. We know there's much more work to do, and the work of this organization is vital to do it. So I want to thank you all for your work. I want to continue to partner with Less Cancer to understand the risks that are out there and the work that needs to be done. And I just want to conclude by saying thank you. Thank you for sharing your stories, for devoting your time to this important cause. And thank you for standing up for your families and all of our families and communities as we work to lessen the incidence of cancer and work toward a world with less cancer. Thank you all so much.
Hi, I'm Congresswoman Terry Sewell, and I proudly represent Alabama's 7th Congressional District, the Civil Rights District, which includes the historic cities of Birmingham, Montgomery, Tuscaloosa, and my hometown of Selma, Alabama. I want to thank Less Cancer for inviting me to join you for today's 2023 National Cancer Prevention Workshop. I'm proud to call Less Cancer a partner in the fight to eliminate health disparities and pave the way for a world without cancer. The past 2 years have been like no other, given the threat of the COVID pandemic. COVID-19 put a spotlight on health disparities, but we didn't need a pandemic to know that. Since coming to Congress in 2011, reducing health disparities for underserved communities has been a top priority of mine. And as co-chair of the Ways and Means Racial Equity Initiative, I have fought to bring health equity to the forefront of our policy agenda. Tragically, cancer takes the lives of over 600,000 Americans every year and disproportionately impacts minority and rural populations due to the high rates of late-stage diagnosis. We know that one of the most important ways to beat cancer is to catch it early, before it spreads. If you or your loved one is diagnosed with cancer, the very next words you want to hear are, "But we caught it early." Until now, our tools to catch cancer early have been limited, but today, thanks to cutting-edge advancements, new blood-based cancer screenings are emerging, which hold the promise of catching cancer earlier than ever before and treating it before it spreads. Unfortunately, unless Congress acts, it could be a decade or longer after FDA approval before Medicare has the authority to cover these new cancer screenings. Just as Congress has acted in the past to create coverage for mammograms and other screenings, we must act again. My bill, the Medicare Multi-Cancer Screening Early Detection Coverage Act, would help us do just that. This legislation would modernize Medicare coverage to enable providers and seniors to access early detection screenings after they are FDA approved. The premise is somewhat simple, but it would make a big difference for the thousands of families who face cancer diagnosis each day. At the same time, it would help reduce the glaring disparities in cancer deaths between racial groups. Thanks to our persistent advocacy, this bill received bipartisan support, a majority of bipartisan support in both House and Senate in the 117th Congress. I pledge to continue in the 118th Congress to continue this fight to make sure that it's passed and signed into law. As we enter this new era of cancer screening and treatment, we must ensure that the benefits of these new tools are felt by all of our people, especially rural and underserved communities, which have been historically left behind. That means being intentional in ensuring that equity is at the center of our policy making. I applaud the Less Cancer Board for shining a spotlight on health disparities during today's event. What keeps me going is knowing that what we do today will save countless lives years from now and pave the way for a world free of cancer. To the scientists and experts at today's workshop, thank you for your commitment to this worthwhile cause. I firmly believe that these new technologies and advances in early cancer detection is going to be our best chance to save lives and reduce the burden of cancer. Together, let's continue this fight until cancer as we know it no longer exists. Thank you.
Hey, everybody, it's Bill Cousins again. I wanted to use this opportunity to talk a little bit about our next representative, Dan Kildee from Michigan. He's done some extraordinary things with PFAS, PFOS, the forever chemicals. His story is very relevant to today's subject of health disparities, health access, and cancer. We know living downstream is no win, and that people who live at these primary sites where these chemicals are being discharged have circumstances that are less than ideal. They're living in poor industrial areas, sometimes rural areas, but they don't necessarily have the resources to move. They don't have the health access. The situation is not ideal. Less Cancer is grateful to all of today's legislators, and special thanks to Representative Kildee, who has really been working very hard at cleaning up this forever chemical issue. Thanks so much.
Thank you to Less Cancer and Mindy Messmer for inviting me to speak to you today about the work that I'm doing in Congress to protect veterans and communities impacted by dangerous PFAS chemicals. As many of you know, PFAS are a group of forever chemicals that have been used for decades on military bases and in consumer products. PFAS chemicals don't break down in the environment. They never go away, and they're linked to numerous health issues like cancer and thyroid disease. For decades, veterans were exposed to these dangerous chemicals, which were used in firefighting foam on military bases. Across the country, more than 700 military sites have been identified as having known or potential releases of PFAS. Many of them are in my home state of Michigan. These PFAS chemicals have leached into nearby communities' groundwater and the private wells, exposing over 100 million Americans to these PFAS chemicals, according to the Environmental Working Group. More needs to be done to protect our veterans and communities from PFAS exposure. We need to stop putting new PFAS chemicals into our environment, to fully understand the scope of the problem and to focus on cleaning up contamination. That's why I created the bipartisan Congressional PFAS Task Force. Working together across the aisle, we've passed legislation to end the use of PFAS in firefighting foam in the military, to increase spending on cleaning up PFAS at current and former military bases, and to get the EPA to create safeguards from PFAS in our drinking water and in the environment. But there's still more to do, especially to take care of the veterans and families who've already been exposed to PFAS chemicals. That's why I introduced the Veterans Exposed to Toxic PFAS Act, or the VET PFAS Act, to ensure that our country takes care of the veterans and families who've been exposed to PFAS chemicals. This legislation would require the VA to cover the treatment of health conditions related to PFAS exposure, including certain types of cancer. No American should have to worry about whether their drinking water contains potentially cancer-causing chemicals. In Congress, I will continue working to combat and clean up PFAS chemical contamination. Thank you very much.